Care Hospital, Talegaon, Davade. So welcome you all for the conference. So we are starting with the first scientific session of today in the auditorium, the faculty paper presentation. So I would like to invite the chairpersons for today's session, Dr. Sandhya Kulkarni Madam, Professor and Vice Principal, Department of Microbiology, MIMR Medical College, and Dr. Smita Pire, Professor and HOD, Department of Pathology, MIMR Medical College. I welcome the judges for the today's session, Dr. Shilpa Kshirsagar from DY Patil Pipri and Dr. Jayashree Kharchana from Atal Bihari Vajpayee Medical College. So I would like to request chairperson to introduce the judges, please. Dr. Shilpa Kshirsagar, judge for today's session. She is Professor, Department of OBGY from DY Patil Medical College, Pune. Her special areas of interest are high-risk obstetrics, social obstetrics, lactation, and she is also a passionate writer. She has more than 20 publications in various national and international journals, and she has received Women by Excellence, Nari Ratna, and Dr. Smita awards. She also has received various awards for writing, reels, and photography. I welcome you, ma'am, for today's session. Thank you.
Good morning. I am here to introduce another judge for this session of faculty award presentation. We have Dr. Jayashree Kharchana. She is MD EMD Physiology. Currently, she is working as Associate Professor in the Department of Physiology at Atal Bihari Vajpayee Medical College, Pune. She is also Medical Education Unit Coordinator at the Institute. Her total teaching experience is 23 years and 440 publications, out of which 21 are international. She is a reviewer for many journals. She has published 3 books and she has written 3 chapters in the books. Her main area of interest are medical education, yoga, exercise, diabetes, hypertension. She is also a resource faculty for various workshops. I welcome both of you, ma'am, and we would like to start with the session. Thank you all.
Thank you, ma'am. So we are starting with the scientific session. I will call upon the first paper presenter for today's session, Mrs. Sangeeta Tripathi. The topic is Association of Oxidative Stress and Dyslipidemia in Patients with Multibacillary Leprosy. So the time given, first day will be at 6 minutes, second will be at 7 minutes, and later 2 minutes of question answer session. Like that will be there for the presentation.
Good morning everyone. I am presenting the paper Association of Oxidative Stress and Dyslipidemia in Patients with Multibacillary Leprosy. Leprosy is a disease of great antiquity, and in India the prevalence rate of leprosy has significantly decreased from 57.2 to 0.57, but still the new cases arises continuously and indicating the continued transmission of the leprosy. skin and nerves occurs the respiratory pulse. This respiratory pulse leads to production of the reactive oxygen species such as the nitric oxide, superoxide anion, hydrogen peroxide, etc. When the generation of these reactive oxygen species increases above the normal level, the oxidative stress occurs. The lipid peroxidation is the oxidative destruction of the polyunsaturated fatty acids in the membrane, and the serum MDI is served as a sensitive indicator of the lipid peroxidation. When the lipid peroxidation increases, it could lead to decrease the total lipids. Hence, the present study aimed to assess the oxidative stress and its correlation with the lipid profile in multivascular leprosy patient. This aim was achieved by the following objectives. The primary objective to estimate the serum malondialdehyde as an indicator of the oxidative stress in multivascular leprosy patients and normal subjects. To estimate the serum lipid profile in multivascular leprosy patients and normal subjects. The secondary objective was to study the correlation of the oxidative stress indicator with the lipid profile in multivascular leprosy patients. The present study was carried out in the Department of Biochemistry in collaboration with Skin and Bleeding Department at Maiman Medical College, Kolhapur, Dagadi. Study was approved by the Institutional Ethical Committee, and the study was designed as the observational case control study. Sample size was calculated by considering the standard deviation of the MDI levels reported by the Jyoti et al. So the calculated sample size was 80, and it was divided into the two groups. The group of controls comprises of the protein normal age and sex-matched individuals. Group 2 multivascularly. The 40 patients of the multivascularly diagnosed according to the WHO criteria, characterized by 6 or more skin lesions, involvement of more than one peripheral nerve, irrespective of the lesion count, and a positive skin smear at any site. Inclusion criteria for cases newly diagnosed multivascular leprosy patients in the age group 21 to 60 years and for control normal subjects in the age group of 21 to 60 years, leprosy patients with history of smoking, antioxidant supplementation and chronic inflammatory diseases, and also the leprosy reactions and past history of the treatment of leprosy patients were excluded from the study. The tail of the passing venous blood was collected and separated serum was used for the estimation of biochemical parameters like the malondialdehyde and the lipid profile. These are the various methods which was used to estimating the biochemical parameters like the malondialdehyde and the lipid profile. Student unpaired details applied for the analysis. Peer correlation coefficient was used to find out the relationship among the MDI and the lipid profile. P-value less than 0.5 considered as the statistically significant. The serum MDI levels were significantly increased in the multivascular leprosy patient when compared to the control. The MDA modified HDL is taken up by the scavenger receptors and degraded in the liver lysosomes. The elevated levels of tumor necrosis factor decreases the lecithin cholesterol aside as far as activity. This enzyme is required for acidifying the cholesterol in the HDL, so impairing the HDL formation and reduce the cholesterol levels in the HDL cholesterol. Similar findings was observed by Kuppale and other studies, while the Kazimazumita reported normal LDL levels in the multifacetary leprosy patients. Oxidative stress increases the hydrolysis of the triacylglycerol to release the free fatty acids. These free fatty acids are further utilized for the energy purpose and also the membrane repair. These free fatty acids are also good for the peroxidation and cause the depletion of the triacylglycerol stores. Similar findings were observed by the RLASK study and the other researchers. While the Menon reported an increase in the triacylglycerol levels in the multivacillary leprosy patients, which is contraindicated to our study. The study revealed the relative correlation between the oxidative stress markers, MDA and lipid profiling multivacillary leprosy patients. Reduced concentration of the lipids are seen in leprosy patients due to the oxidative stress. Multivacillary leprosy patients show increased severity of the sleep lesion and nerve damage, which is associated with significantly elevated oxidative stress. The limitations of the study was, this was a single center study and patient dietary history was not recorded, which may be the confounding factor for this study. The future scope of the study to tracking the oxidative stress. These are my references. Thank you.
Questions?
Very nice study and nicely presented. Even the results and observations discussion was very clear. My question is, when you said that it is age and sex match with the control, so you took the similar, like you haven't mentioned that in the results, whether how many female, how many males, how many demographic. So whether that was matched.
Yes, madam, that was match for the age and sex also.
And second thing is routine checkup. Are we really getting those many patients for routine checkup? Because whenever a patient is coming to CCL, most probably he has some condition, maybe some fever or any hypertension, diabetes, something. Because in inclusion criteria you have excluded the patients with diabetes. So was it possible?
Yes, madam, informed consent you have taken for this.
No,
And also the case history
Control group.
for control groups.
Okay. Thank you. Hello, ma'am. Again, it was a nice presentation.
Thank you, madam.
My question is that age is 21 to 60 years, which is a wide range. So doesn't the higher age affect oxidative stress levels or MDA levels?
Yes, madam, we have taken this 20 to 60.
Which is a wide range. So how
The aging is also causes the oxidative stress and the frequency of the leprosy patient in our hospital is in the adult leprosy patients. That's why we have taken the age group 21 to 60. But one of the limitation of this study is that it must be divided into the 2 or the 3 groups according to the age.
and how also we can detect from MDA levels the prognosis of the disease? How in MDA levels, how they are useful, at what stage of the disease they can be detected?
HDL levels,
MDA levels.
MDA levels, MDA levels will be also increases when the bacterial burden is increases. In the multivaccinary group, there are the some patients of the borderline tuberculine, borderline lepromatous and the lepromatous leprous. The bacteriological index can be derived from +1 to the 6+.
That is also affect MDA levels.
That is also the limitation of our study.
chronic rhinosinusitis with nasal polyps, coexistent asthma, using biologics. What are biologics? Biologics are monoclonal antibodies. These are targeted proteins, large molecules, usually synthesized using cell cultures, and they are large molecules in comparison to small molecules like our standard pharmacotherapeutics. They are targeted molecules. So basically, biologics for nasal polyps would be targeting immunoglobulin E and interleukin 5, 14, 3. So there are currently molecules available and FDA approved for this purpose. The first molecule is Ipilimumab, which is a interleukin 4 and interleukin 13 signaling blockade. It reduces the polyps and improves the sense of smell. It is given as a subcutaneous injection. Then it is Omalizumab, which targets IgE antibodies, and there is Mepolizumab, which targets IL-5 antibodies. That being said, I just want audience to see this. This is a custom-made molecule synthesized using the genome and the protein sequences. And these protein sequences are in turn fed into the computer. Artificial intelligence determines the structure of the molecule, complementary domains. Then we find those complementary domains and we synthesize proteins which latch onto those complementary domains and create their effect. So this is the highest level of science, highest level of technology. So using artificial intelligence, molecules can be synthesized and they can be used for targeting the specific interleukins and antibodies and immunoglobulins. This is the complex structure of interleukin 5, which is being targeted. As this picture is not showing actually, it is taken up from the public domain, and you can see the electron dense regions that another protein will go and bind. So the role of biologics in asthma is Omalizumab, Mepolizumab, Risulimumab, Benralizumab, and then for targeting severe asthma with oral steroid dependence, Tezepelumab. Again, they are all ending with AB because they are monoclonal antibodies. So why should we do a research? Why is this research importance? Because as far as allergy and polyps are concerned, there is only 2 treatments available in the market right now. One is your anti-glucose inhibitors, second is your antihistaminics. There is no other third available. The only thing you can do is give steroids. Other than these 3, there is nothing is available. So this is the another frontier of treatment that is opened up for treatment of polyps, especially polyps. Because polyps, when it comes to polyps, the only treatment available is surgical. Either you can give steroids or you can do surgery. So this is the third frontier and important frontier that is opened up as treatment. The only problem currently is the cost. As we shall see, one of the parameters of my research is the cost, how much it costs in India. It's very expensive, but as the prices are coming down in coming years, it may be possible to treat patients with monoclonal antibodies as time progresses. This is the parameter of the study is called PICO. PICO stands for population, intervention, comparator, and outcome. So these are the 4 PICO parameters that are taken up. And we did a search strategy. It's a systematic review. We had a search strategy. We searched Medline, Embase, Cochrane with the clinical terms, with these MESH terms. MESH stands for medical subject headings. So we dug out those MESH terms relevant to our study from PubMed, and then we applied those MESH terms and made the search. And this is PRISMA framework. We have followed all the guidelines, standardized guidelines for conducting meta-analysis. And studies records are identified with 11,906, out of which we screened 7,543. Finally, we included 19 meta-analysis, 19 studies for our meta-analysis. This is the PRISMA framework. And finally, it filtered down 4 biologics: Ipilimumab, Omalizumab, Mepolizumab, and Benralizumab. These are the 4 biologics we finally filtered it down for our study, for our analysis, because these are the ones that are effective against nasal polyps and bronchial asthma. So, after pulling the data and doing a combined statistical analysis, we concluded that this is the score we got. We put the standard mean deviation, and then we got the effect size as large, and the total participants were 2,218 patients. And this is our forest plot. What you can interpret from the plot is that there is benefit from the treatment, as you can see. there is effect of biologics in asthma, in reducing the asthma exacerbation rate. Next is your polyp reduction. So polyp reduction again, as you can see, this is called a standard fast plot. You can see that there is definitely benefit of reducing the size of the polyp when it comes to using these four biologics. And then there is the smell and nasal symptom score, which is also very much improved. So we found that there is significant benefit in our analysis. So quality of life is also improved, and the effect is quite good, clinically meaningful improvement, and the number of patients we put data improved is 2021. Now finally, like all meta-analysis, we look for heterogeneity. Heterogeneity is to check, because we have taken studies from different populations. One is an Indian, one is American. So we have to see whether all the data is compatible with each other. So we did a heterogeneity analysis and we found that there is low to moderate heterogeneity. And this is the funnel plot, which shows for publication bias. And the adverse effect, this is what we found. And most common adverse effect is the pain on the injection site, and that is more common with omalizumab. And finally, we looked at the availability. We found that they are available in the major cities. And the cost. And the cost is prohibitive. Even the cheapest biologics cost 2.3 lakhs per month. And the most expensive is benalzumab, costs 7.5 lakhs per month. And we found that the drug most adverse effect is dupilumab, and the most common adverse effect is injection site pain. We found that all these four are quite effective in reduction nasal polyp burden, sinonasal symptoms, and asthma exacerbation in adults with polyps. And this is beneficial in patients who are refractory to standard line of treatment. Thank you.
Good morning, sir. Again, it was a very nice study. I just want to ask how many researchers were included in the meta-analysis?
All my meta-analysis include my wife, and of course, people in my department, Mani sir and my HOD sir, they were included.
Because generally 3 or more researchers is beneficial, no? Because lot of literature has to be gone through.
Yes, ma'am.
And all the resources which you have mentioned, Medline, Cochrane, are they freely available at your institute, or how do you access them?
We have subscription access. We have subscription access to clinical key. We have up-to-date. So that's not a problem.
And few of the studies are observational and few are interventional, experimental. So why mixed studies have been included? Does it create a bias?
Yeah, that actually causes a bias. But we were wanted to increase the number of patients.
Okay.
We just started filtering out. We could not get the number of patients to make the analysis, because not all studies give the data.
Right.
Observation studies especially don't give data. We need data for making the meta-analytic part. That's why we had to use more.
Thank you, sir. Nice statistical
Thank you.
analysis done.
Very nice, novel,
Thank you.
something. I just want to ask, you have said since inception to 2025 you have included those studies. So what was the first study about the inception? Because in India cost is quite high. I don't feel you got many studies from India.
If I remember correctly, the first published biologics are 15 to 20 years back.
20 years.
Last 15 to 20 years back, but slowly it is coming up. This our integrated biologics are last, I think, 7 to 10 years ago.
Okay.
So we have to integrate.
And you mentioned that the best is some Hopkins study. So what made you to make it best? Is it only some score or overall the fallacies and overall study?
I guess the score that we got, because it's all statistical. So we got some scores, then that forest a lot. So based on that score, I guess it's not related with the study itself. All studies were of good quality. We screened the top quality studies.
So it is rather effectiveness of drug rather than the study.
Yes, effectiveness of the drug was the key feature.
Oh, okay.
What were the keywords? Why was you search keywords for microcard?
Biologics, dupilumab, and name of those four biologics, and then chronic rhinosinusitis, refractory bronchial asthma, quality of life, nasal symptom improvement score, hyponasality, nasal obstruction, likewise. It's not. Thank you.
Thank you, sir. Call upon the next presenter, Dr. Madhu Bansode, study of clinical and laboratory parameters for nutritional assessment in elderly population of a tertiary
Good morning to all of you. The title of my research paper is Study of Clinical and Laboratory Parameters for Nutritional Assessment in Elderly Population of a Tertiary Rural Healthcare Setting. Malnutrition in the elderly is a significant health concern, particularly in the low and middle income countries where access to adequate nutrition and healthcare services may be limited. The aging process brings about physiological changes that affect nutritional needs, that is decline in the muscle mass, reduced appetite and a slower metabolism being the key factors contributing to malnutrition. So it often manifests through various clinical signs such as weight loss, reduced physical performance and an increased risk of comorbidities like anemia, sarcopenia and osteoporosis. The WHO has identified malnutrition as one of the major public health concerns in the elderly. Malnutrition is a dynamic and multifactorial condition, meaning that its prevalence is affected by numerous variables such as geographical variation, socio-economic status, underlying health conditions and access to healthcare. So the aim and objective of my study was, the first objective was to study clinical and laboratory parameters for nutritional assessment in the elderly population, and the second objective was to study the association between age, body mass index, protein energy malnutrition, iron deficiency anemia, vitamin B12 deficiency anemia in the elderly. Material and methods. The study design was a cross-sectional observational study in a tertiary rural healthcare setting, and around the study population was around 50 patients, and they were studied using tools such as mini nutritional assessment and laboratory markers like serum albumin, iron, B12 and total iron binding capacity, as well as anthropometric parameters which I will be coming through, alongside demographic, social variables like spousal loss, caregiver presence or not, then polypharmacy, that is more than 5 medications, then comorbid illnesses, whether there was any hospitalization and the functional status of the patient. So methods for nutritional assessment was by clinical assessment, then history taking and symptom evaluation, medical and medication review, and functional assessment by the ability to perform activities of daily living such as dressing, bathing, cooking, eating, etc. Anthropometric assessments was by body mass index, waist circumference and waist to hip ratio, also mid-upper arm circumference and skin fold thickness. Then laboratory assessment was by complete blood count, red blood and red blood cell indices, then serum albumin, electrolytes and minerals, and fat-soluble vitamins like A, D, E and K, and the C-reactive protein. Dietary assessment was done by 24-hour dietary recall and food frequency questionnaire and the mini nutritional assessment. Data analysis was done by one-way ANOVA test since there were many variables, and also a chi-square test and independent t-tests were used for data analysis. One-way ANOVA for age group differences in the serum albumin, B12 levels, TIBC and serum iron, and inferential statistics like chi-square test and independent tests were employed to study association between nutrition and the various health parameters. Observation and results. We stratified the patients into participants and patients into discrete 3 age cohorts, that is 65 to 75 years, 76 to 85 years and more than 86 years, and examined the social determinants also like spousal loss and caregiver presence, etc. It also sought to determine how well standardized screening tools like this mini nutritional assessment will correlate with simple bedside measures like body mass index, triceps skin fold thickness, hand grip strength and activities of daily living. And also these with the laboratory markers such as serum albumin, B12, iron and IBC. So this study identified key nutritional risk factors like among the 50% or 50 participants, 70% were at the risk of malnutrition and 6% showed frank malnourished status. So these were the observations. So I'll be coming into details that. So the summary of the study is that around of the 50 rural elderly patients, 52% were females and 42% 48 were males. Then the primary occupations, 20 were in farming, 14 patients were in, the occupation was labor, they were laborers, then 11 were housewives and 5 were retired. Spousal status, 52% experienced, they did not have a spouse to take care of. Then the caregiver support was around 48% only received the caregiver support. In the chronic diagnosis, 16 patients had both diabetes and hypertension, 9 patients had only hypertension, 8 patients had only diabetes, and 17 had no diagnosis. Comorbid profiles, 12 patients had hypothyroidism, 11 had hypertension, 7 with diabetes, and 20 with no comorbidities. Polypharmacy, 18 patients used more than 5 medications, so which had an impact on the nutrition part. 14 patients had hospital admissions, at least one hospital admission in the last 1 year. 35 patients had were showing at risk of the nutritional assessment. In the nutritional assessment, they showed at risk of malnutrition. 3 were malnourished and 12 were normal. Functional independence, 33 were able to have a functional independence. Then the BMI categories, 6 were underweight, 23 were normal weight, and 17 were overweight, and 4 were obese. And tricep skin fold thickness, 12 were having a low thickness, suggestive of frailty. And so regarding the laboratory, serum albumin levels were around, all the 3 cohorts had around the lower side of normal, on the lower limit. Vitamin B12 levels, the mean B12 was 276, 286 and 336 respectively in each of the groups. Then total iron binding capacity was around 309, 296 and 336. So likewise the iron levels, nutrition and the BMI was assessed. Conclusions. So this cross-sectional study of 50 elderly individuals from a rural center revealed that 70% were at the risk of malnutrition despite most maintaining independent activities. And the preservation of functional ability alongside widespread clinical nutritional deficiencies indicates that physical independence is not a reliable indicator of adequate nutrition. Anthropometric data showed dual burden of malnutrition, 12% were overweight and 42% were 12% were underweight and 42 were overweight. Biochemical analysis showed that there is an age-related decline in the serum albumin and increases in vitamin B12, serum iron, TIBC. Point to be noted was the elderly population was having B12 supplements. So in our study it was found that there was an increase in B12. And statistically significant associations were found between age group, nutritional status, BMI category, with younger adults most vulnerable to undernutrition, middle-aged elders showing rising trends of overweight, and the oldest elders maintaining some resilience. So, and finally, social determinants played a critical role. 52% had lost a spouse, then comorbid conditions and polypharmacy were prevalent. Recent hospitalizations were associated with lower BMI and albumin levels, and age-specific interventions are essential, especially including early supplementation for young adults, younger elders, dietary and physical activity guidance for middle-aged elders, and maintenance-focused strategies for the oldest groups. These are my references. Thank you.
Nice study, ma'am. Mini nutritional assessment and one more tool you use. Is it already pre-validated?
Yes, ma'am.
It is already
These are pre-validated.
And the questionnaire you had that were also
Yes.
available already pre-validated or
Yes, yes. So it is already a questionnaire, questionnaire, that how many meals and what is the nutrient values, and accordingly it is calculated.
So, did you analyze it according to the nutrition or you just did observational study?
So we found out, so in each of the group, we just filled up the questionnaires and later on there was an analysis done.
Yeah, but like, did you divide them into the categories like who are getting the
Yes,
proper
yes.
nutrition and who are not getting the
Yes,
nutrition? Because
so in each of the three cohorts and finally the total. So the 3 cohorts we did and found out whether they are in
So
the
what kind of supplementation do you suggest for elderly? Because in your study almost B12, iron.
So the clinical implication is supplying good amounts of iron, B12 and
But
protein.
iron and B12 is, at least in your study, I know to make a generalized statement, number is very less. But
Yeah, the limitation
iron
of the
and
study was it was a
B12.
small size study and there were many variables. So, but the 65 to 75 age group, the first young elderlies, did have they were at the risk of malnutrition, and then likewise, but the middle group had some caregiver support, and the third group we found that they were already having supplementation.
Hello, ma'am. Nice study. But basically, in your study, there were too many parameters and too many
Variables.
Variables, I mean to say that comorbid conditions, people were also included. Non-comorbidity were included.
Yes.
And ideally, it should have been divided the persons who are having comorbid conditions, those who are not having it. I think the statistical analysis should be more elaborate, which will further help you to find some clear results.
Yes.
Otherwise, it is good.
Yes, thank you.
Okay.
I will call up the next speaker, Dr. Gauri Pitkar, malaria-related pseudocounts and scattergram abnormalities in automation. Good morning. I am presenting malaria-related pseudocounts and scattergram abnormalities in automation. Introduction: modern-day automated hematology analyzers work on the principles like flow cytometry and multi-angle light scatter to classify blood cells. Although highly sensitive, these analyzers may generate atypical results or artifacts when confronted with intravascular hemolysis, parasitized RBCs, and immune activation in malaria. The hematology analyzer artifacts mainly depend on 2 factors, that is physical properties of malarial hemozoin pigment and working principle of automated hematology analyzer, which include flow cytometry and light scatter, like forward scatter for determining cell size, side scatter for internal complexity and granularity, and side fluorescence for nucleic acid content. The hemozoin pigment, which is formed by degradation of hemoglobin by malarial parasite, is engulfed by monocytes and neutrophils, and this results in them getting unique light scattering properties and physical properties such as granularity or ability to depolarize light, similar to true eosinophil granules, and this results in pseudo-eosinophilia. And the abnormalities in WBC scattergrams, like fusion of neutrophil eosinophil clusters, graying of WBC clusters, duplication of WBC clusters, etc. The mechanism of pseudo-NRBC detection involves detection of NRBCs by WNR, that is white blood cell nucleated RBC channel, which utilizes a specific reagent which lyses the mature RBCs while preserving WBCs and nucleated RBCs. The NRBCs are counted properties. The parasitized RBCs are resistant to the lysis by this agent because of presence of hemozoin pigment, and they also contain malarial DNA and RNA nucleic acid contents, which helps them to get stained by fluorescent dyes, and hence they are calculated as nucleated RBCs. So with this background, these analytical artifacts have the potential to trigger unnecessary reflex tests or mislead clinicians about hematological abnormalities. So with this background, analytical evaluation of RBC and WBC interference patterns and artifacts in automated hematology analysis in malaria cases was the objective of the study. This was a prospective descriptive observational cohort study which was conducted between March 2025 to November 2025. All malaria positive cases in the No negative controls or comparator cohorts were included as the objective of the study was to quantify artifactual patterns exclusively in malaria positive samples. So results, total 18 diagnosed malaria cases were analyzed based on inclusion and exclusion criteria. Demographic profile shows the age range between 6 to 57 years with male dominance, that is 61%. This is the table which is showing statistics of artifacts on hematology analyzer. So here we can see pseudoeosinophilia was, the mean value was 7.2%. Out of 18 cases, 11 cases showed pseudoeosinophilia accounting for 61.1% with 95% confidence interval 79.7. Nucleated RBCs were seen in 6 out of 18 cases with a mean value of 48.5 per 100 WBC, and abnormal WBC scattergrams were seen in all 100%, that is 18 cases. So from this table we can see that pseudoeosinophilia and abnormal WBC scattergrams are commoner finding than nucleated RBCs. The unique findings about pseudoeosinophilia was absence of hemosol pigment within the neutrophils and monocytes even after extensive reviewing of all the peripheral blood smears. So, which is the postulated mechanism in the literature. So, we offer an additional mechanism of pseudoeosinophilia, that is presence of schizoid forms of Plasmodium vivax which are actually mimicking eosinophils. This finding is supported by absence of pseudoeosinophilia in Plasmodium falciparum cases and Plasmodium vivax with less trophozoite forms and purely falciparum positive cases. So this is a photomicrograph which is showing schizoids of Plasmodium falciparum which are mimicking eosinophils. The other forms of Plasmodium seen were trophozoite of Plasmodium vivax, gametocytes of Plasmodium falciparum and ring forms of both Plasmodium falciparum and vivax. The pseudo-NRBC detection showed 2 prominent cases showing as high as 639 per 100 WBC and 277 NRBCs per 100 WBC. Many abnormal WBC scattergrams were seen. So this is a reference diagram showing separate neutrophil and eosinophil clusters, etc. So when we come to the actual cases, we can see there is significant increase in eosinophil detection which is given out by the analyzer. And here we can see, if we see this scattergram closely, we can see there is fusion of neutrophil and eosinophil cluster and prominent dots which indicate host cells. Similar findings are seen in other cases, elevated eosinophil count and fusion of neutrophil eosinophil cluster. Other findings were elongation of monocyte lymphocyte cluster, double WBC population, graying of the WBC zones and NRBC clusters. Other studies also found the similar findings which used other hematology analyzers like 6-mex XC2100. So conclusion is flow cytometry and light scatter based automated hematology analyzers demonstrate characteristic artifacts like pseudoeosinophilia, NRBC and abnormal scattergrams. Recognition of these patterns facilitates early suspicion of malaria and prevents misinterpretation of CTC abnormalities such as hypereosinophilia or erythropoietic stress. The clinical implication of the study is combination of fever with eosinophilia and or NRBC elevation should prompt clinicians to suspect malaria and advise confirmatory tests like peripheral blood smear or rapid malaria antigen test. The limitation was small sample size and no control group. So future larger study population with positive and negative controls to determine sensitivity and specificity and formation of malaria suspicion criteria with these findings. Thank you.
Hello. It was a nice study. Again, you already pointed out the sample size was very small. And what measures you will take to reduce these artifacts?
Actually, what is observed is once the schizoid count decreases, these artifacts are automatically cleared. So it is very difficult with the present technology that is used in hematology analyzer to reduce these artifacts because they are seen not only in
malaria, you should suspect malaria. So you are going retrospective.
The problem is, ma'am, at some centers, like only CPC is advised, peripheral blood smear is not done, and clinicians.
That's what I'm asking. That your study included cases with confirmed malaria.
Confirmed means when we got the findings, we compared both CPC findings as well as the diagnosis of malaria. So confirmation was done prospectively.
Okay.
Thank you.
Okay, thank you, ma'am. We will be continuing the rest 2 sessions in the afternoon. For today's and afternoon, the faculty paper presentation will be continued. I would like to call on the chairperson and the judges on the stage, please. Yes.
मॅडम अश्विनी मॅम वाईट लावला ना कॅमेरा
Like to felicitate the judges for today's session. The judges will be continuing for the afternoon session as well, but felicitation is right now. So I will request Dr. Sandhya Kulkarni ma'am to felicitate Dr. Shilpa Kshirsagar ma'am.
सेंटर
Thank you.
Thanks to the judges, chairpersons and the speakers of the first session. Now we are going to directly kick off with the next session. There are two next sessions and they are going to be very interesting and very exciting. They are going to touch the day-to-day clinical areas of the doctors and of the patients. So I will request the chairpersons, Dr. Madhu Bansode Madam, who is the professor and head of the Department of Medicine, and Dr. Pooja Swarma Madam, who is the associate professor of Department of Surgery, to please come on the stage. So the immediate next session is going to be on the back pain, and speaker for this session is very prominent ortho spine surgeon Dr. Arjun Dwale. And now I will request Dr. Pooja Swarma Madam to kindly introduce Dr. Arjun Dwale. Thank you.
Could you please come? It gives me immense pleasure to introduce our esteemed speaker, Dr. Arjun Dwale. He is the additional director of spine surgery at the Department of Orthopedics and Joint Replacement at Sir H.N. Reliance Foundation Hospital. After completing his orthopedic residency at Bombay Hospital, Dr. Dwale worked at reputed medical institutions in India and North America, where he did his fellowships in adult and pediatric spine surgery. He is also the faculty at H.N. Reliance Hospital for MUHS Spine Fellowship and DNB Orthopedics. Dr. Dwale has more than 35 publications in high-impact, peer-reviewed international journals such as the Spine Journal, Spine Deformity, the Spine, to name a few. He's a peer reviewer for many reputed journals. Dr. Dwale has an extensive academic portfolio and has over 50 scientific presentations on national and international platforms. He's a member of various societies like Scoliosis Research Society, Indian Orthopedic Association, Royal College of Surgeons of Edinburgh, Association of Spine Surgeons of India, North American Spine Society, and Pediatric Orthopedic Society of India. Dr. Dwale's special interest lies in scoliosis and spinal deformity in children and adolescents, degenerative lumbar and cervical disorders, minimally invasive spine surgery, to name a few. Without further ado, may I now invite Dr. Dwale to shed some light on how to approach backache, which I think no one in this audience has escaped from.
Respected chairpersons, senior professors, associate professors, and my colleagues, I'd like to extend my gratitude to Dr. Santosh, who invited me for this program. And we go back a long time since our MS days. We were batchmates. So thank you very much. So back pain, as Madam alluded to, is probably the single most common problem that everybody has. It is the most common reason to visit a doctor. It is the most common reason to miss work. And there are many causes for back pain. Not all of them are orthopedic or musculoskeletal. Many times it can be referred also. So one needs to have, clarity when one is assessing patients with back pain. And, a lot of it has to do with our lifestyle. We are sitting, desk jobs, the incidence of back pain is increasing. Now when we look at any person who comes to us with back pain, the most important thing is to look at getting a good history and also understanding what are the red flags. So what are the problems which you must not miss when you see a patient. A person who complains of a little bit of back pain, more when the day. But a patient who has rest pain or pain with fever or weight loss, and those things need to be looked at in association, so not in isolation. At the same time, we don't want to add anxiety to patients because they have back pain. So that's the yellow flags. Now, as we've been taught, right from second year of medical school, you have to look at the characterization of the pain, the onset, duration, progress, whether the pain radiates, what are the aggravating and relieving factors, and keep a sort of high index if there is rest pain, if there is weight loss, if there is fever, if there is weakness or palpable environment. After we get a good history, you have to examine. So the examination obviously does start with the spine, but you have to examine systemically and check that there are no other associated issues. A simple algorithm is to look, feel, move and measure. In orthopedics it's a very simplified way. In orthopedics we try to think and look at everything very simply. So this is just to show you how we examine. Now always the examination should ideally be without very much clothing, because otherwise you will tend to miss. Also you must look at the neck. Now for example, this is what we call the forward bending test, the Adams forward bending test, which is used in school screening programs to pick up scoliosis in adolescents. For example, this is a girl, she came to us who looks quite normal, but when you make a bend forward, you see that there is a rhythm, and this is how the scoliosis was detected, and actually that's the curve. So, if you don't examine the patient without clothes, you can completely miss this. This is another patient, and if you see carefully, this patient on the skin has capillary spots. And you can see the capillary spots there and the rhythm. The capillary spots are a manifestation of neurofibromatosis. So, this is what the child had. The child had a very severe scoliosis with scalloping over the brain. This was then treated with surgery. This is the outcome. So, when you practice, I don't think one can practice, orthopedics in isolation or spine in isolation or medicine in isolation or pediatrics in isolation. I think your basic fundamental foundation in all subjects is important when you are in clinical practice, whether it is physiology, anatomy, pharmacology, microbiology, because everything plays a role in how we manage. This is another child, 6-year-old girl, and you can obviously make out she's got a severe scoliosis. But here, there is a very large curve. Yeah, this is a syndrome. This child had a Ehlers-Danlos syndrome. So understanding, the genetic component also is important. And this child was treated differently with the growth rod system. So where we basically try to distract the spine as the child grows. Again, this is how. Now the other part of the examination which is very important is the neurological examination. You have to look at the power, the tone, the reflexes, look at the sensations, ataxia, the patient is able to walk tandem or not able to walk. Why is this important? Because many times you will pick up a thoracic or a cervical problem just on the neurological examination. So for example, this child, she came to us with this very large kyphosis. It's almost a 90-degree kyphosis. And this is actually post-tuberculum. In our country, tuberculosis is endemic, and many times deformities are missed. And in fact, this child is actually from Pune area. And you can see that severe deformity there, destruction of three vertebrae. You can see what's happened to the spinal cord. The cord is completely dented. And then this required a surgery which is involving a resection of the vertebral column and a fixation. But this child presented with myelopathic signs. So they had imbalance by walking, early signs of hyperreflexia, So if this is not picked up early, then child will come with paraplegia. So this shows the outcome. What about investigations? So laboratory tests are required many times. Radiology, basic X-rays, and MRI conclude the diagnosis. For example, this is to show you different types of presentations of tuberculosis of the spine. So you can see here that there is abscess in the vertebra and there is involvement of the disc space. And this is to show you varying forms. So, where the spine is straight, there's a little kyphosis and there is more deformity. And you can see there's destruction of many vertebrae and severe spinal cord compression. TB remains to be a very, very important subject. Again, something where there is a amalgamation with microbiology, physician, infectious disease, and we see a lot of these patients still, unfortunately. And usually we offer conservative treatment when there is normal neurology and no significant compression, and we offer surgical treatment when there is neurological compression and spinal deformity. However, the mainstay of treatment remains correct antibiotic treatment for the tuberculosis. The surgical role is less. And as time is going by, we are seeing more and more patients with multi-drug resistance because of incorrect chemotherapy and improven diagnosis. So for example, here this is just X-ray. But you can see on the simple X-ray of the chest, there is a large spherical swelling like a fusiform abscess which you can pick up. You can see on the lateral X-ray that there is a kyphosis. So a simple X-ray will tell you almost as much as what the MRI is going to show you if you look at the X-ray carefully. This is to show you the large abscess and the deformity, and this is what was done. Biopsy confirmation is necessary and the culture probe. So this is looking at a study which we did at, to look at drug resistance, and we found almost 40% incidence of drug resistance in children. And what about the lab tests? So usually we do a CBC, SR, CRP. In tuberculosis, you must look at the liver function test. Patients who come with rest pain or having morning stiffness, you have to look for non-spinal causes. So sacroiliitis, spondyloarthropathy, you look at HLA-B27, you look at the RA test. Patients who come, older patients who come to us with osteoporosis, you have to look at, to look at the evaluation for osteoporosis patients, especially who come with fractures, because sometimes you can have myeloma which can be missed. Many times they'll have vitamin D deficiency, a very common problem. Now what about X-rays? X-rays of the spine usually we advise that they are done septic. So for example, this is a girl, spine looks quite straight, and you can see that it looks like there is a scoliosis. If you just look at a simple X-ray from the front, and you might label this patient as having scoliosis. But if you do a lateral X-ray, you can see that there is a very high grade slip of the vertebrae. You can see that vertebra has completely slipped there. Okay? And that is what we call a spondylolisthesis. And this is a flexion extension X-ray which we usually do many times, to see how much is the mobility. And then we get an MRI which shows that there is compression of the dura, and then treatment is in the form of fusion. What about MRI CT? We don't want to overdo this, but we need to do them when necessary. So for example, this is the X-ray, it looks quite okay, nothing much on the X-ray. But if you look carefully, you have a little bit of lucency in the vertebra. Okay? So good radiological viewing on the X-rays will pick up some problem. And if you see that, it comes out to be osteoblastoma. So a simple evaluation of an X-ray can go a long way in picking up a diagnosis. That osteoblastoma then required, you see the cord is compressed out there, dural compression, and this patient then required removal of that tumor, and then with ribs we have reconstructed. Now this is another patient, okay, this is just to show you 40% of this is at work, okay, so probably, for students, also this is a problem. Also becomes an issue when you're giving fitness certificates to people who come to us for medical treatment. How much rest should be given? Now there are two types of pain. One is a back dominant pain, which is intermittent, and that's a good thing because basically that is not showing any damage to nerves or spinal cord, and that usually does not require surgery. The other time is a leg dominant pain, which we see with patients who have a disc problem and what we commonly call sciatica, sciatica. Now, sciatica is actually a misnomer because that is if the sciatic nerve is, but it seems to have been called that even if it's coming, it's actually a radiculopathy. Now, this pain usually feels better when you lie down. And this often gets better simply by itself. 95 to 98% of patients who present with sciatica should be treated conservatively. There is no role for surgical intervention for a majority of the patients. Simple rest, simple analgesics, simple lifestyle modification and physiotherapy are what is required. Sometimes you need to further check on them with MRI, and rarely an epidural steroid injection can be a sort of intermediate way to treat them. Now this injection can be given by the anesthesiologist, it can be given by radiologists, it can be given by the orthopedic doctors. So many things are multidisciplinary. So for example, this was a 25-year-old, he had severe left leg pain for 2 months. Second episode worsened, did not benefit with steroids, did not benefit with the injections, non-steroidal anti-inflammatories, and he was unable to work. You can see that the scoliosis which develops this way is many times a list. You can see there's a very large disc at L4-5. And this patient then was treated with a microdiscectomy, with a tubular microdiscectomy. And this is, we use a microscope. Okay, this is Dr. Chaudhary, who used to be my colleague. Now this is a second type leg dominant pain, which is when you walk, what we call claudication. So from medical school, we've been taught about claudication, vascular claudication, neurogenic claudication. How do you differentiate between the two? Climbing upstairs, climbing downstairs. So all this actually has great application in clinical practice. So when you see a patient, you must always check the pulse to rule out any vascular causes. You must always check the neurology because you don't want to rule, label a patient with a vascular problem as a neurogenic. Okay. Now this is very common in older patients. Older patients who will come, so with difficulty in walking more than a few meters or maybe more than 10 minutes, and this is because of the pinch nerve. Okay. Now this leg dominant pain, sometimes there may be a role for surgical intervention if conservative treatment fails. Okay. For example, this was a 69-year-old patient. He had leg pain more than back pain. Claudication, unable to heel walk, worsening of symptoms, and had some neurological manifestation. You can see that there is a spondylolisthesis there with a lysis. Okay, you can see that crack in the L4. This patient required surgery, but many times surgery is not necessary. This is just to show you how it's done. Now this is another patient. Okay, X-ray looks quite okay, nothing much on the X-ray. But you see the MRI shows multi-level stenosis at L2-3, L3-4, L4-5, and here you can see that the stenosis is severe. And this patient then requires treatment if they don't settle. Now, with current technology, many advances have happened. Spine surgery once upon a time was considered very unsafe and, outcomes are poor. But, now there are many ways to make things safer. Of course, there is no substitute for training and clinical, correct clinical practices and indications. But you do have many ancillary things like navigation, neuromonitoring. So probably one of the greatest advances developed by a physiologist, basically where you can actually monitor the electrophysiology of the spinal cord during surgery. For all these scoliosis surgeries, cervical spine surgeries, we actually monitor the SSCP and the MEPs during anesthesia. Again, this requires the anesthetist to be involved. So you are actually able to know that the neurological function is maintained when you are doing these surgeries safely. Now there are things like 3D printed models which you can make, so that you have a assessment and you can plan the surgeries better. Now the back dominant pain where there are red flags, you need to understand. Most important is bowel bladder involvement, or if there's numbness in the perineal region or if there's weakness in the legs, what we call cauda equina syndrome. This is an emergency and this patient needs to have treatment within 24 hours, okay? Another problem, patients who present with fever, weight loss, tuberculosis in the past, any immunocompromised patient like who's diabetic, patients who are on dialysis, transplants, IV drug abusers, because in these patients you have to keep a high index of suspicion for any infection. So for example, this was a 60-year-old person who had CKD, diabetes, pulmonary hypertension. He presented with history of fever with chills. Usually you will think of urinary tract infection, but you have to rule out any spinal problem here. So here you see the X-ray looks okay. But if you see the MRI, there is a hyperintense shadow at L2-3, which is because of the spondylodiscitis. You can see that very clearly, the marrow edema there at that L2-3 level on the STIR sequence. So you can understand how important the radiological, sort of assessment is and how much you have to work as a team. There's another 28-year-old male. He came with severe back pain, fever, okay? He had nothing except simple back pain for 7 days. He was referred by a colleague. So we got his MRI done, okay? The MRI showed a huge epidural abscess in the thoracic spine. This patient got admitted in the night. In the morning when I saw the patient had lost power in the lower limbs. We had to do thoracic laminectomy on an emergency basis. And this turned out to be, you can see the abscess. So you can see the abscess there on the sequence. I'm showing you the actual images here. You see there's a large abscess in the thoracic spine. And you can see that's the focus in the chest. That's the focus in the chest. So this turned out to be a staphylococcal infection. And it turned out to be MRSA and needed vancomycin. So again, it is treatment along with the physician for the right problem. And you can see the clearing up of the infection later on. Now, fractures, big problem in old patients, okay? And a lot of patients probably here you see who have trauma. So after serious accidents, after falls, understanding when to clear the spine. Older patients complain of back pain, always you should get an X-ray done because many times a trivial fall will also cause a fracture. So for example, this was a 25-year-old male, he had a train accident. Very fortunate, he had only back pain, nothing else. You can see there is a burst fracture of L5. The whole canal is completely obliterated here. That fragment has gone backwards. And we just did a simple stabilization of this, minimally invasive. And to show you how the body heals itself, we did not do any laminectomy, we did not do anything. But this is just to show you that how on its own that bone fragment which was there auto-resorbed and the entire spinal canal has reformed. Okay, so now this is a patient, you can very clearly make out that there is a fracture of L2. If you see that the vertebral height is reduced of that L2. Anybody can make out. Anybody sitting here will be able to make it out. We do a bone density test. On the bone density, you will see that there is osteoporosis. Now, you can see that red is osteoporosis, green is normal. And you start osteoporosis treatment. So, for our elders in our family also, this is something you need to look at. We start bisphosphonates. There are other options like teriparatide, denosumab, vitamin D, calcium brace. So again, this is all pharmacology. Pharmacological treatment forms the mainstay. Sometimes, you can have, something like a cancer picked up with back pain. So a patient might just come with back pain and, unfortunately may turn out to be something else. So for example, this was a 32-year-old patient. He had just come with little back pain for 2 weeks, not radiating. He came back after 2 days saying that I'm not better. So MRI was recommended. Otherwise, I would not recommend an MRI for somebody who comes for 2 weeks back pain. But then if a patient comes back, so remember if a patient comes back to the emergency or comes back to the OPD within a short duration of time and is not better, then please have a higher index and investigate further. So this was the X-ray, it didn't look like there was anything. But on the MRI, you can see that there are multiple vertebral involvement marrow lesions here, okay? And this patient finally turned out to have a lymphoma, which was then proven. So many times you will find something else. This was a 6-year-old child who came with vertebra plana. You can see that there is one vertebra which is completely, destroyed there. And this is to show you the MRI. This patient, after biopsy, turned out to have Ewing's, okay? And you can see that we have done a embolization there with the radiologist and then done a resection of that entire vertebra. You can see that entire vertebra is being removed here, okay? So a resection of the vertebra after chemotherapy, okay? Now, X-ray, CT scan, MRI, when should you do what? CT scan we don't like to do very often because there's high dose of radiation. You want to kind of keep it when you require it only. Again, should we ask for MRI for every patient? No. Because if I did an MRI here of everybody sitting here, 2/3 will have a problem. 2/3 of the people here sitting will have some problem, some disc, and then what happens? The radiologist will write everything that they see. And now the patient doesn't understand the MRI, but they see the report. And then they come worried to you. Oh, what has happened here? I have problem in this disc, I have problem in that disc, I have problem in this disc. Now what should I do? Now that is not a good thing. There is no correlation between the severity of degeneration and symptoms. So patient may have an MRI which is bad and clinically may have nothing. Or it may be vice versa. Okay? So it's very important that our role is to allay the anxiety of patients who are not presenting with any clinical symptoms and who are on examination normal. And probably one of the greatest statements ever made, that physicians think that they do a lot for a patient when they give his disease a name. So we think we are doing something great by making a diagnosis, but are we really, or are we just creating anxiety for the patient? So we have to understand what we are saying, modulate what we are talking, how we talk to each other also in front of the patient. And what you create is this: I have a bad back, I should stop exercising, I'm not well, I can't go to work, I cannot play. So for example, this is another 55-year-old, he had back pain and tingling numbness in the lower limbs, okay? He had no other problems. Now, this patient was actually referred by a hepatologist to me. X-ray was okay. This is the MRI. In the thoracolumbar area, there was a problem here, okay? And we could see that this patient had like a sudden deterioration neurologically, and there was compression of the cord there. I bring this up because it's a rare problem, and in the emergency you should not miss such problems. This is to show you the PACS, how the PACS imaging, it's better to see the PACS images rather than seeing the films, because the films are many times given by technicians. While the images, if you look at yourself, you will not miss something. So if you look at the imaging in the PACS system in the college, it will be better than looking at just MRI films, okay? This is just to show you how you run through the the PACS images. And this patient actually had a hematoma. This was a hematoma which was intradural, an intradural hematoma which required to be removed. And if this is not picked up on time, then the patient will have paraplegia. I mean, a very rare thing. Usually this can happen in patients who have some AV malformation, or if they are on blood thinners. So you have to, keep a history, take the good history basically. And this patient had DSA later. Now this is another 45-year-old male. He came with back pain, but he was a karate teacher. Okay, he had spasticity, developed difficulty in walking and weakness. When you do an MRI or you look at the lumbar spine, never forget to screen the whole spine. So one of the topics I gave one of my students right now was to look at the incidence of other pathology on whole spine screening. And there is a very high incidence of other pathology which you will find, which would be missed if you just do a limited MRI. So wherever you are doing the scan, always it's important that you look at the entire spine so you don't miss. So for example, this patient, though he came with back pain, you can see the cervical spinal cord is severely compressed. Severely compressed, okay? And this patient, you see now again, you can see the cervical spinal cord compression there. Again, you will be able to make it out very clearly, okay? This patient had a severe compression and OPLL, okay? And he had actually stopped walking almost. And this patient then had a cervical laminoplasty, and then he started walking. Okay, so that's to show you, we make a hinge. We make a hinge, open it up so that the cervical spine has space. Okay. So the yellow flags. Now, what are the yellow flags? Fear and avoidance, low mood, isolation, fix me. I mean, I'll do everything. So I'll do Ayurvedic, I'll do massage, I'll do chiropractor, I'll do, I'll spend a fortune basically. So patients spend unlimited resources. So many patients, the sad part is that for cancers and for back pain, patients spend fortunes selling land, etc. to, go for alternative therapies which may really not be beneficial, because many times problems sort on their own, okay? So how we advise and counsel is very important. What works? Bed rest for a short duration if there is acute pain. It's important to move. It's very important that you are keeping not indefinitely, few sessions and then you switch to a home program. Active exercises, to improve your core. Changes in lifestyle, sitting correctly, having limited time, seeing that you do things properly, having correct posture when you lift up things, and cognitive behavioral therapy. And multidisciplinary care, not just by the orthopedic doctor, but by everybody involved in the care, because eventually the role of the spine surgeon is very, very limited. I have picked up cases here, but suppose I see 100 patients in a week, I may be advising surgery for 2 or 3 patients. Other patients I will be maybe just managing medically, understanding what the diagnosis is, and referring appropriately. So to understand back pain, one has to have knowledge, because the eyes cannot see what the mind does not know. Always rule out other problems. There are other problems like renal colic, which can present, pancreatitis, referred pains because of other reasons. So never fixate. I think it's very important that your foundation is strong so that you can practice appropriately. Thank you very much.
Thank you, sir. Thank you, sir. That was an excellent session. Wait a minute. So that was amazing because a lot of the red and yellow flags were covered very well. And now I would like to throw the floor open to the audience and we can take about 5 questions. So if anyone would like to ask anything. Sir, I'd just like to ask, which are the red flags that are generally overemphasized? I know there are red flags and of course Cauda equina and all other ones, but there are some that are overemphasized and over-investigated, though we can't do anything about it. So would you like to throw some light on that?
So, I mean, one thing would be, so many times patients have back pain, central, many times it's post-viral. Like so many patients with chikungunya or dengue, etc. will present with back pain, but patient will come to you first because they have back pain. Everything will go on a wrong tangent only. But it's important that you sort of systemically see that what else is going on. Otherwise, you will think this is a patient who's coming with back pain, put him on some anti-inflammatory. Actually, it is a viral infection. Many patients with viral infections, like chikungunya, for example, they will present with musculoskeletal problems, state back pain. You will think it is. The other thing is fever. Now, fever can be, having many causes. I have brought this up not to scare anybody, but to increase awareness. And when we are assessing, to keep that broad-mindedness, I'm not saying ask for MRI for every patient. I don't think that is the answer. That is the wrong thing to do. But when you clinically feel that there is high index, then you should do it. I mean, I would not, it's very difficult to generalize. I think it's important that each patient, the beauty of medicine is actually that every patient is different. It is not like an AI algorithm or an engineering thing or a maths class where everything kind of is through a factory line. That is actually the greatness of medicine and why it's so interesting to practice, because every day you see something different. You learn something different with whatever you're doing. Thank you.
Thank you so much. Anyone else?
Sir, myself Dr. Rajiv Munde. My question is that a lot of the patients, when they come to OPD, always ask, they see all the videos, that's a chirotherapy thing. Come on, doctor, do some manipulations and then some cracking sound and then patient gets relief. So is it really works or is just a quack type of thing? A lot of people ask such kind of questions. And if it is working, then how it will work?
I didn't get the question. Your voice is
Chirotherapy, manipulation.
So I do not recommend, clearly I am saying, I do not recommend chiropractor therapy because sometimes you can create damage with manipulation without understanding what is happening. I always recommend physical therapy because physical therapy is local modalities along with building up your own body to do the exercise. So the strengthening exercises actually help. The core strengthening helps your back. The neck exercises help your neck. It is basically making you learn to do what you need to do. But psychologically, if somebody cracks something, the patient feels better. But it can be counterproductive sometimes. If a patient has got a severe cervical stenosis and you do it, you can land up with problems. Yeah. So, I mean, that's what I'm saying. To blindly do things is not good.
The second question is that a lot of patients like in older age, more than 60, 70 years, those are having the severe osteoporosis. They come with some scoliosis, with the fracture type of things. Do we need any surgical treatment for them or just it will work the teriparatide or some...
So generally if a patient has osteoporosis, we are advising treatment to prevent fractures. Most commonly hip fractures, sometimes spine fractures. So in a patient who is post-menopausal, it is better to have one bone density done during annual checkup sometimes, maybe once in, bone density need not be done more than once in 3 years. On the basis of that, if there is Osteopenia, you need to just treat with calcium vitamin D supplements. If the patient has osteoporosis, which is T-score less than minus 2.5, then the treatment needs to be initiated after correct workup. One of the problems also is that there is over therapy given now. Over therapy means we are treating more than we should. Treatment should be what is required, and also it has to be as per what the patient prefers. Most patients prefer simple oral medication, which is bisphosphonates, which can be given either once a month or once a week. That should be the first line. If the patient does not tolerate that treatment because of gastritis, or if the patient has renal issues, then other treatments are offered, which is like denosumab, which is once in 6 months. Teriparatide actually has a limited role. It is best to be given when vertebral fractures are there, or after a osteoporotic fracture, or after we do a orthopedic or a spine surgery for fusion. It is not to be given for every patient, and it has to be given only for 2 years.
Thank you so much. Sir, there is one question here. Sir, it was a very wonderful talk and very enlightening talk. I would like to ask you one question. A lot of patients comes to us with chronic backache, and I'm a psychiatrist. So a lot of time they were referred to psychiatry saying that it is a fibromyalgia and all those things. So patient do ask us whether we can do yoga, Surya Namaskar and other yoga practices by Ramdev Baba and all. So what is your opinion on this?
So I think it's good. Yoga is good. However, yoga in its extremes can cause injuries. Because many times in yoga, what is propagated is extreme flexibility, and which may not be physiological for a particular person. Somebody who is not doing it and suddenly tries to do too much is going to land up injuring himself or herself. The other thing is to label fibromyalgia, it's a diagnosis of exclusion. And I never label anybody to have a functional cause of pain. So I had a patient, she was a physiotherapist practicing in the UK. Okay, I'm giving you this story just for understanding. Had a very anxious personality. So she actually went to the gastroenterologist first, had only little bit of abdominal pain. He examined, he said, I don't think there's a problem. He sent her to me. She said, no, I'm having back pain for 6 months. I've been to NHS, I've been to doctors, I've been to my GP, there's no problem. I also thought maybe it's an anxiety problem, but I said, no, I just said, okay, let's get an MRI since you're here. The MRI showed that there was a thoracic spinal tuberculosis with cord involvement, and the patient's pain, which was the band-like pain, was coming from the intercostal neuralgia. She had significant compression, she had surgery, and she was actually a very pleasant girl. She had surgery, she improved, she still comes to visit when she comes to India, but she could not get an MRI done for 6 months, and unfortunately, a patient's personality can make us label them as functional without appropriate investigation. That mistake we should never make. We should never make that mistake of labeling somebody as functional until we are absolutely clear that there is no organic cause, because that is wrong.
Thank you very much, sir.
Yeah.
Sir, in paralysis patients, nerve regeneration is possible with any technology?
For?
Paralytic patients, after the paralysis or hemiparalysis.
So for patients who have a spinal cord injury,
Yes, after that if they land up in
so there is many times possibility of recovery if appropriate treatment is given. If there's transaction of the cord, no. But if there is just a limited injury, like a cord level less, but if it's root level, sometimes there can be cord equina and below. If a patient presents with paraplegia because of tuberculosis, usually the recovery is very good. Almost all the patients recover. If a patient presents with paraplegia because of a pyogenic infection, the recovery is less. And if a patient presents with a full cord transaction, it's not going to happen. Like a road traffic accident with a cervical spinal cord injury or something, then it's unlikely. The stabilization is basically to allow sitting and basic activities. A lot depends on the ASIA scoring, what we call the ASIA grade. Is it sensory, motor, incomplete, complete? A complete cord injury, unlikely to recover. Partial, higher chance. So your patient has monoplegia, most likely will recover. Patient has, some power, not complete. Up to 1 year, there can be chance of recovery. Up to 1 year. But in those patients, there is role for short term, like initially, suppose patient comes in the first 8 hours, we can give Solumetrol within 8 hours. After that, there's no role of steroids. And of course, stabilization if there is issue or decompression. But we cannot generalize. But up to a year, patients can show recovery, yes.
And stem cell therapy is there something?
Of course, therapy is very important. So in all these patients...
Stem cell which will replenish damaged nerve?
I'm not sure.
Thank you.
Thank you very much.
So that was a very interesting and informative session. Lot of case examples from pediatrics to geriatrics, covering infective back pain and everything. Now we are going to start with the next session. The next session is by a very prominent pharmacologist, Dr. Jayashree Dawane Madam. So I will request Dr. Jayashree Dawane Madam to please come on the stage. And the chairperson, Dr. Madhu Bansode Madam, is going to introduce Dr. Jayashree Dawane Madam. Thanks.
So we come to the another interesting session, and this is by Dr. Jayashree Dawane, who is a professor from Bharati Vidyapeeth Medical College, Pune. She is a MD and PhD in pharmacology and has a 30 years of teaching experience. She has expertise in modern pharmacology and herbal medicine. She has around 59 publications to her credit, with 13 research awards and 13 copyrights granted. She has presented 25 scientific research papers at the national and international conferences and organized and conducted 18 workshops for postgraduate students of modern medicine and Ayurveda. She also serves on institutional ethics committees across medical, dental, and Ayurvedic disciplines and is a nominee for CCSEA. So, welcome, ma'am, and we look forward to your interesting lecture on pain perception and pharmacotherapy.
Good morning to all. Thanks, Madhu Madam, for the introduction. Today, we are going to explore a very critical and challenging topic, that is pill pain perception, a multidisciplinary approach to the rational pharmacotherapy. At present, we are living in the era of medicinal as well as the pharmacological advancement. Still, there is a painful thing which remains. Chronic pain remains a global epidemic, and it is affecting almost 1.5 billion people worldwide. And the simple answer for the people, for the all you can say, is a pill. Does this pill is effective? But it has been proved that the pill is inadequate in completely providing the relief, and many a times resulting into the severe adverse effect because of these drugs. And by this pharmacological treatment or a pill often not enough to treat this complex experience of the pain. So for that, we need to understand what is pain. So pain includes the third component, which is not taken care by the current treatment, is the perception. So drug treats the disease, drug treats the symptoms, but it does not take care of the perception which is associated with the pain. So requires a multidisciplinary approach or multidisciplinary solution for that. So what is pain? In a simple language, pain is not just a signal, but it is a story that mind wants to tell us, mind chooses to tell us that as per the International Association of the Study of Pain, it is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Now you see here, it includes the sensory as well as emotional experience. So we can say that inherently pain is the emotional thing. Then it shows the subjective phenomena. Two persons do not respond in a similar way to the pain. And it is context dependent. Again, one more thing is important. Pain is not always equal to the trauma or injury. It is a protective output from the brain against the perceived threat. So fundamentally, pain involves or pain includes the biopsychosocial aspect, not only the social or not only the biological. So we need to understand this, and accordingly we have to go ahead with the pain. Now, for the understanding of the pain, pain can be acute pain or pain can be a chronic pain. Acute pain is for a short duration, whereas chronic pain, which is lasting more than 3 months and involving more than 2 hours per day, it is according to the definition. And different types of pain, pain can be nociceptive pain, arising from the nociceptors which get stimulated and resulting in, because of it, could be musculoskeletal pain or arthritic pain which is getting involved because of this nociceptive receptors in the somatic system, as well as the visceral pain which is coming from the internal organs such as heart, liver, intestine, or many more. So typically we want to treat this pain with NSAIDs, or if it is in the severe form we prefer to use the opioids. Another type of pain is the neuropathic pain, which is resulting because of the damage to the nerves or the damage or inflammation near the nerves. It could be resulting. It is typically presented in the form of burning sensation or shooting sensation. Example is diabetic pain, diabetic neuropathy could be the good example, or you can say trigeminal neuralgia, where the typical neuropathic pain is there, and it often requires the treatment with agents or the anti-epileptic agents they are used, or the drugs like gabapentin or pregabalin, they are preferred for treating the neuropathic pain. And third type of pain is the nociplastic pain. Particularly, exact pathology is not there, but the pain sensation, they are treated in a little different way. So it could be a fibromyalgia or chronic widespread pain. And here you require the multimodal approach for the treatment. Now, what is available with us? What are the different drugs, or you can say pharmacological pillars over here? So usually when pain is there, we want to use the drugs which are available, with drugs which are proven for their safety and produce the minimal adverse effects in the patients. So established therapies such as NSAIDs can be used, which are the COX inhibitors for addressing the inflammatory pain. And if the pain is more severe, we would like to use the opioids, which are effective in treating the moderate to severe or severe type of pain will be treated. But the risk associated with the opioids is that there is development of tolerance and dependence could be there. And even at the therapeutic doses, sometimes they cause the respiratory depression. Some adjuvant drugs are there, established drugs are there to treat the neuropathic pain, like tricyclic antidepressants, anticonvulsants, corticosteroids, etc., but they are used as an adjuvant only. Some drugs are emerging drugs, you can say emerging innovations, which are under development. They are not still completely proved or available. These are vanilloid receptor antagonists are in the development, which will be used to treat the pain coming from the heat and inflammatory changes. Then CGRP, that is calcitonin gene receptor peptides, they are available, and this is the revolutionary research for the treatment of the migraine. Then voltage-gated sodium channel inhibitors, since these voltage-gated sodium channels are associated with the pain, so inhibitors of these channels would be very useful in treatment of the pain. Then cannabinoid modulators are also tried because they are involved with the sleep, they are involved with the day-to-day activities here. So finding out a drug which will be helpful in the treatment of the pain. So why these monotherapies usually we give to the patient for the relief of the pain, they fails or do not show the complete response. It comes over here with the side effects or the adverse effects which are associated with these drugs. So gastric symptoms or gastric tolerance is associated with the NSAIDs, gastric ulceration, erosion, peptic ulceration could result because of NSAIDs. 2, the cognitive impairment or cognitive fog is resulting from certain drugs. Often this diminishes the quality of life of the patient as much as the pain itself. Then tolerance and dependence, the chronic use leads to the diminishing efficacy, whereas the adverse effect profile goes on increasing. So if opioid episodes has taken the lives of hundreds of the patients because of the dependence and tolerance developed to them. And one more important thing which we need to remember is that the efficacy ceiling. So as you go on increasing the dose of the drug, because the given dose is not sufficient to control the pain in these patients, but later on development of tolerance is there. As you go on increasing the dose of the drug, the adverse effects increases, but the efficacy reduces. The benefits received from these drugs gets reduced. And another important thing, they neglect the psychosocial aspect related with the pain. So they fail to address the emotions, they fail to address the cognitive and environmental drives, and that's the reason for the failure of monotherapy or the therapies which are given with the pharmacological drugs at present. So for that, we need to understand what is pain pathophysiology and pathology in short about it. The 4 processes they are involved in the sensation of the pain. One is transduction. So whenever pain is felt by the patient, it is because of the stimulation of the nociceptors, the nerves, the nerve fibers, small nerve fibers, delta A and C fibers, they carry the pain impulses to the spinal cord. And from this noxious stimulus, an electrical signal is generated which reaches to the spinal cord. In the spinal cord, the transmission of these signals takes place along with the spinothalamic and spinoreticular tract, and the perception is felt in the brain, which emerges through the integration of the sensory and emotional processing. Both the components gets mixed over here. The response of the brain in the descending pathway, it lies in the descending pathway for the feeling of the pain. That is, descending pathway releases or sometimes act through the serotonin, norepinephrine and endogenous peptide like endogenous peptides, which are similar substances which released from the brain similar to the opioids, and they relieve the pain. So the key neurotransmitters which are included here, they are substance P, glutamate, calcitonin gene related peptides which are acting and modulating the pain which is perceived by the patient. In short, about the gate theory for knowing about the perception of the pain. Now, gate theory, Malzac and Walsh, they proposed this gate theory, and it states that transmission of the painful signals can be modulated, or it is modulated at the nerve gate. And what is the nerve gate? Nerve gate is located in the Dawson Hall cell. That is, the impulses carried by the first order neuron and transmitted to the second order neuron. At this level, at this phase, the modulation can take place. So non-painful signals coming from the other myelinated thick nerves can block these painful responses at the nerve gate. So how these painful impulses modulated, who are the influencers, who modifies these painful signals? These are non-painful sensory inputs such as touch, pressure, then cognitive factors such as attention, distraction, emotional states such as anxiety and mood of the patient, and descending pathway, as I said, release of the endorphins as well as the effect on the substance P and other these neurotransmitters. So when you see that if the patient is feeling pain, if you rub that area, if you apply the cold to that area, pain is minimized. This indicates that the painful impulses, they are blocked at the level of the spinal cord and they are not further carried by the ascending pathway to the CNS. So placebo effect is very important here. Placebo effect, that is a pain reduction with the positive expectation. So while and placebo effect, if you give a substance to the patient which is not pharmacologically active, yet it causes the relief of the pain because of the release of the endorphins. Whereas the nocebo effect or negative effect will increase the perception of the patient pain by the patients. So expectation itself modulates the pain experience. Coming to the power of context and expectation, as I said, cognitive and emotional states profoundly affect the perception of the pain. So perception, which is very much neglected, is the important aspect in while treating the pain. So attention, anxiety, fear, depression, they also modulates the pain intensity. And as I said, placebo effect is observed by many. This works in the acupuncture therapy particularly, or some massage therapies. Pain gets relieved because of the non-painful impulses. Next is the nocebo effect. Nocebo is a negative expectation which worsens the pain feeling. Even if you say to the patient that this particular drug is going to produce so and so adverse effect, and you administer the placebo substance, patient experiences that adverse effect with that particular drug. So this is nothing but the nocebo effect which is experienced by the patient. And for that, we need to remember in a clinical practice, though two patients operated by the same method may show different response to the pain or different feeling, and this is the subjectivity of the pain. Psychological factors also produce the effect on the pain perceptions. Very, very important. Psychological influences the pain because they actively amplify or diminish it through the shared pathway. The same shared pathway in the brain is there. So they amplify the responses of the pain. Catastrophizing, this is nothing but the magnification of the pain experience. Patient feels that this is the worst pain and the prognosis for this pain is not good. It is going to be worsened and I am suffering from the pain. This is the feeling which patient gets, and this need to be taken care of. Then kinesophasia, this is another thing where patient feels that any activity he will do or she will do that increases the intensity of the pain. So he is worried about it, he thinks about it. Psychological impact worsens the condition and increases the pain in these patients or in these individuals. Again, stress and mood disorders, they also affects the intensity of the pain in the patients. Depression, anxiety, then chronic stress, these are nothing but the different factors, and they are carried out along with the same path to the CNS, and that's why the processing and amplification of the impulses takes place and pain perception is increased by the patient. So what is the answer here? As in our previous lecture you have heard, multidisciplinary approach is needed to treat the pain. So here, what is the multidisciplinary approach? A robust multidisciplinary approach includes the three core pillars here. As we have understood, perception is a very important thing. So first, naturally, will be the pharmacological treatment, that is a pill, medical management, optimizing the pharmacological treatment, using the appropriate drug at the appropriate time, could be in the form of injection because it treats the psychology of the patient, and some diagnostic specialties should be used. Next thing is that the physical or occupational therapy, because fear of movement is there in this patient, so fear should be removed with the psychological counseling, you can say, or occupational therapy, restoring the normal movements. Normal movements gradually help to reduce the pain. So building the strength and facilitating in terms of the meaningful activities is the another aspect related to it. And psychological, behavioral health. For this, different psychological settings, they are required consulting psychologists, and different sessions need to be taken from the psychologist in the form of this PNE, that is the Pain Neuroscience Education, and CBT, this is Cognitive Behavioral Therapy, which helps a lot to reduce the pain in the patients. So continuous assessment is needed. Continuous settings are needed to minimize the pain. So plan the treatment after each of the meeting to the patient, how much pain patient is feeling, does it reduce or not reduce? If he is feeling the same pain, try to find out the reason for that. So what is the role of cognitive behavioral therapy? What exactly is done in the cognitive behavioral therapy? It is nothing but the talk therapy. Talk with the patient, try to understand the problem, counsel the patient properly, focus the changes on the patient's perception of the pain and response to it. So its goal is that shift the focus from I am helpless against this pain to I can function despite of the pain. Even if the pain is there, I can function, I can work, it will not disturb my day-to-day activities. And this can be done by identifying the negative thoughts in the patient, try to remove these negative thoughts about the pain in the patients as well as modify the behavior of the patients. So here, one more thing we have to concentrate on, treating the mental illness if it is associated in these patients. So depression and anxiety should be treated, phobias or post-traumatic stress disorders, care should be taken off. Obsessive compulsive orders may be observed in certain individuals and eating disorders are also seen. So you need to treat this psychological aspect at the same time. What is this pain neuroscience education? Now in the pain neuroscience education, teaching the pain, how the pain happens, or how the patient feels the pain, that is also needed. And patient has to understand that the pain which is pursued by the patient is not equal to the damage which is caused. So pain is not equal to the pain damage in the patient. And you have to explain that this is the protective phenomenon in terms of the pain is anticipated by the brain to the patient. So chronic pain happens due to the sensitization of the nerves, nerve endings and CNS. So you need to concentrate on emotions, stress, belief as well as the sleep and explain the patient about the nerve sensitization. So how it can be done, how it can be delivered. Ask the patient about the belief, about the pain, what he feels, how he feels, what is the intensity of the pain he is experiencing or not. And then explain it in the simple languages, reassure about the healing. This positive impact is very, very important. Reassure the patient, he is going through the pain, but soon he will be going to recover from the pain and no pain will be there. Then encourage the graded movement. As I said, physical movements naturally help to reduce the pain and provide short-term home advices, what should be done at the home. So how the pain can be measured? So normal pain scales are there. This is the numerical rating scale which shows you the figure from 0 to 10, which shows the intensity of the pain, no pain to severe pain. So ask the patient about the pain. Since it is a subjective, you need to ask to the patient how much pain he is feeling, show it on the scale. Then visual analog scale is also available to measure the pain, and here the faces are shown and accordingly you can label how much pain patient is suffering from. And this scale, visual analog scale, is very useful in the children to measure the pain. Third, this scale which is available for measuring the chronic pain is that verbal descriptor scale. So patient may not be able to show it on the numerical scale or visual analog scale. It is better to ask him verbally how much pain is there, how much is the intensity, and how much is reduced in terms of just in the form of roti or chapati. It's, how much part of this chapati is relieved and how much is remaining. In the simple languages, you can assess this pain measure. Available for measuring the pain is MAGRU questionnaire. Now this is the little bit extensive questionnaire, and this includes the multidimensional aspects for capturing the sensory qualities, but it provides you the additional information about the affective dimensions as well as overall intensity of the pain can be obtained from the MAGRU pain questionnaire. This is necessary. Repeated assessments, they are necessary at the regular interval, which helps the clinician to plan the treatment, to adjust the medications, and to evaluate the effect of their intervention. That's why these scales can be used for the assessment of the pain. So which drugs can be used and how they are used? The WHO has published a guideline for use of the analgesics in the treatment of cancer, but later on it was applicable, it made applicable for all pain. It could be for the acute as well as the chronic pain. So according to this ladder, step 1, if the pain is mild to moderate, it can be treated with the simple NSAIDs like paracetamol and NSAID. If the pain is a little bit more of moderate intensity, it can be treated with NSAID, and mild opioids can be prescribed over here, like tramadol. And moderate to severe pain here, the NSAIDs, opioids, and the adjuvant drugs may be required. So this was initially published. This guideline was given. Later on, it was modified, and some techniques also included in it. That is interventional pain management techniques, such as you can say local and regional anesthesia or epidural anesthesia, or some more techniques were included into this. Obviously, non-pharmacological aspects, they are very, very necessary as per the WHO as well. That is physiotherapy, psychological counseling, cognition-based therapy, and lifestyle modifications are essential when you are treating the pain. After that, the NICE guidelines, that is National Institute of Health and Care Excellence, introduced some guidelines for the treatment of the chronic pain. Now they focus on the holistic approach here. They are more focused on the functions and quality of life of the patient. And they prefer to use the non-pharmacological measure, and these therapies are more important for treating the chronic pain. So caution use of analgesics, avoid long-term opioids in the chronic pain. So opioids not at all indicated in the beginning for the chronic pain, but the opioids or the, you can say, they are used for the acute pain, not for the chronic. And regular review and deep prescribing is essential according to the NICE guideline. NICE guideline divides the pain into two categories, chronic pain into two categories. These categories are chronic primary pain and chronic secondary pain. Now when you say chronic primary pain, the exact reason or cause is not understood over here, and here non-pharmacological interventions are indicated. So group exercises, psychological therapies, CBT, or the pain neuroscience education, PNE, they are indicated for the chronic primary pain. Chronic secondary pain, obviously we need to find out the reason behind it, identify the reason for the pain, and try to treat this pain reason of underlying cause. In neuropathic pain, as per the NICE guidelines, neuropathic pain is treated with amitriptyline, duloxetine, gabapentin, and pregabalin. Tramadol may be used or considered for the short-term therapy. So these are all the NICE guidelines. So patient should be treated as per the WHO or NICE guidelines. But basic thing is that multidisciplinary approach is needed for treatment of the pain, particularly for the chronic pain. So three main pillars are there: pharmacological therapy, psychological therapy, and rehabilitation, as well as physical therapy. And additionally, you can do lifestyle modification. So normalizing the sleep, maintaining the sleep hygiene, maintaining the nutrition and physical activities, regular exercises, small little exercises are indicated. Take the help of the complementary therapies like yoga, acupuncture, or Ayurveda-based approach if evidence shows that there is a relief of the pain with the help of certain drugs. And patient education to empower the self-management. So to conclude, I can say that pills are essential tool, but rarely they are the full solution. Second thing is that pain is the complex phenomena, subjective experience defined by biology, psychology, and social, biopsychosocial phenomena. And perception is the gatekeeper. Harnessing it is crucial for the management of the treatment. So multidisciplinary approach is the gold standard in the treatment of chronic pain. So pain is inevitable, but suffering is optional. So go for the treatment, go for the consultation, and the true goal for the chronic pain management is not to bring the score from 10 to 0, but our aim is to improve the function, quality of life, and self-efficacy of the patient, which is very, very important. Thank you for quiet listening. And remember, pain management works best when science treats the body and empathy treats the person. Thank you very much.
Thank you, ma'am, for the enlightening talk. You talked on the deeper aspects of pain and things like chronic pain, which are very common, and everybody, nobody misses any type of pain actually. So any questions from the audience? And while you can think of the questions, I can set the ball rolling by asking one question, ma'am. Regarding chronic pain of migraine and arthritis, so you talked of perception of pain. So is there any other method like distractive things like music therapy or something? Can it be added to the chronic pain?
Yes. For actually migraine, the specific drugs are effective which can be used in the treatment, like carbamazepine is a most effective drug. But in that case also, if you use the distractive methods, music is a very good thing, or putting the attention into the different things, that will help the patient too. Particularly, patient comes to know that when the patient is going to get an attack of the migraine. So anticipating that, particularly in the ladies, you can see the before menstruation, girls may feel that that attacks gets precipitated, or after eating some food ingredients, these attacks get. So concentrate on that. Advise the patient about these things to the patient.
Any other question from the audience?
I am Dr. Borkar. My question is regarding the local pain blocks that are being advised every now and then for local conditions as well as general conditions, or sometimes sympathetic blocks are given. So do they really help the patients in the long run, or they are just a temporary measure to tide over the crisis?
They are just the temporary measure. They are not going to help them on the long term. It's very clear. For long-term management, you have to take the multidisciplinary approach only.
Giving steroids for pain, which is not relieved by other methods.
Steroids, again, you know, sir, steroids has got so many adverse effects. So how long we are going to give the steroids to the patients? So again, that is a question.
The muscle relaxants, which are usually advised.
So various drugs can be used. Muscle relaxants can be used if the pain is of different type. Then you can use this local anesthetic therapies also. Epidural anesthesia can be used. But all these have got the limited utility in the chronic pain particularly. Acute pain can be relieved with all these measures. But for the chronic pain, you have to concentrate. You have to give the multi-drug therapy or multi-therapy approach will be there. So combine this. It is not that give the 3 prescriptions and just send the patient. We are giving the multi-therapy to the patient. This is not like that. We have to sit together. We have to talk together.
I am seeing
and
many
decide.
pain clinics popping up everywhere, and they are advising all these treatments, and patients are spending million money on that.
Hello.
Thank you.
Hello. I am anesthesiologist, Dr. Shilpa Gurav. As Borkar sir told, pain clinics are pop, but really it helps. I am suffered for the chronic pain, but I know when I was in the chronic pain physician helped me a lot by giving dorsalis pedis block and orthopedician itself gave me an inguinal canal block. I think you will get a duration when you suffer a lot for the psychological improvement till you means three pillar what you explained over here. I think you get a breathing period from the chronic pain. So I feel ki even regional blocks helps a lot, like epidurally, a single shot of steroid can help, because a lot of means use of steroid definitely is very harmful for the body. But if you are in chronic pain, definitely for breathing time, to act on different modes of to relieve pain like meditation, physiotherapy, pills, and whatever. So I think multi-modular therapy and the role of pain physician is significant, no doubt.
Yes, yes.
Thank you.
Very true. So thanks to her once again.
Just a minute. I have the last question, probably. I want to ask about the historical aspects of the pain, because the history of the human beings and the history of the human evolution is all about the pain, the sufferings, and the battlefields. So how they were able to manage the pain and carry out their activities in the battlefield with the multiple wounds and getting through. Is it psychology or is it something else?
It was not psychology. Some impact was there with the psychology because they are positively charged during the war is there, during the battle is there. They are charged with the positivity. And additionally, pain must be there. That must have treated with whatever available measures were there at that time. Yes.
Nowadays, chronic pain, those are having the gastric symptoms. Practically, post-operatively, what we prefer instead of using the oral or IV medicines, we prefer the patch,
yes.
dural patch. So is there any difference of adverse effect of dural patch, or it is less having less adverse effect compared to the oral medications or IV medication?
Transdermal patches gradually release the drug. So compared to the oral administration of the drug, they are little bit safer than the oral administration. Oral administration directly causes the adverse effects. So comparatively little less, but same adverse effects are there with these drugs also. So we are giving the drug which are slowly released from these transdermal patches. So for many of the cases, these transdermal patches are used, like fentanyl patches are there, or buprenorphine patches are there for treating the cancer pain. They can be used.
Okay, thank you very much. Please take your seat, madam. Now, can I request Dr. Arjun Dhawale, sir, to please come on the stage for the felicitation? Thank you. Dr. Ojas Varma, madam, is going to felicitate Dr. Arjun Dhawale, sir. Can I request Dr. Madhu Bansode, madam, to felicitate Dr. Jayashree, madam, please? Can I request Professor Dr. Jitendra Mane, sir, to please come on the stage and felicitate the first chairperson, Dr. Ojas Padma, madam. Can I request Dr. Professor Tushar Kashne, sir, to please come on the stage and felicitate Dr. Madhu Bansode, madam, please. So now we have finished the first 3 sessions of the morning. We have got only 10 minutes of tea break now. So please, it's only 10 minutes because we are running late today.
Request all to please settle down in the chairs. We are about to start with the inaugural function. May I request organizing team to please request people to occupy the chairs in the audience. Good morning. Once again requesting people standing at the back to please occupy the chairs in the audience. You may also call your friends who might be outside enjoying the sunshine. Once again, on behalf of MIMAR Medical College, I extend a very warm welcome to everybody for this inaugural function and the keynote address. We'll start right away without any waste of time. May I request the dignitaries for the function to please grace the dais. The dignitaries for the day are our chief guest, Dr. Hinal Shah, our executive director, Dr. Suchitra Nagre, madam. Our other executive director will join us shortly. Principal Dr. Deepa Nair, the three organizing chairpersons, Head of Department of Psychiatry, Dr. Anish Bhatt, Head of Department of Pharmacology, Dr. Ganesh Pentewar, Head of Department of Orthopedics, Dr. Santosh Borkar, sir. May I request you all to occupy your chairs on the dais. May I also request our Superintendent, Dr. Darpan Mahesh Gauri, to occupy his chair on the dais. A very warm welcome to our chief guest for this 13th edition of the annual research conference of MIMAR Medical College at Talegaon Dabhade, Pune, madam. It's my proud pleasure to inform you that this tradition started long way back, 13 years of holding an annual research conference, which serves as a platform for our faculty and faculties across the state, as well as postgraduate students. And recently we started with undergraduate students to showcase their research work, and we try to call eminent speakers. And this year, very ably, the three departments have chosen the theme, as you might have seen and observed, of mind, movement, and medication, all three having as much relevance in current lifestyle and times as can be. Mother Teresa said, and I quote, "If we have no peace, it is because we have forgotten that we belong to each other." We at the Mayur family are blessed to have as our founder president, Dr. Vishwanath D. Karad, sir, who has been striving relentlessly for world peace for decades to come. We also try to instill similar such values in our students across the entire institutes of the Mayur group of families. So it is our tradition to start every auspicious event with the World Peace Prayer, a prayer which has been put together by our own founder president, a prayer that does not belong to any caste, creed, religion, or geographic boundaries, but a prayer that asks for peace to dwell and abide on entire mankind. May I request everybody to please rise for the World Peace Prayer. Fold your hands in reverence. Remember your mother, father, your teachers, your gurus, and let us all pray for world peace.
प्रतिपाद्या जय जय स्वसंवेद्या आत्मरूपा देवातूति गणेषु सकलार्थमति प्रकाशो म्हणे निवृत्तिदासु अवधारि गोदी गुरुर्ब्रह्मा गुरुर्विष्णु गुरुर्देवो महेश्वरः गुरुसाक्षात् परब्रह्मा तस्मै श्री गुरवे नमः। पूर्णमदः समुदच्यते पूर्णस्य पूर्णमादाय पूर्णमेवावशिष्यते ॐ शान्ति शान्ति शान्तिः हरि ईशावास्यमिदं सर्वं यत्किञ्च जगत्यां जगत् तेन त्यक्तेन भुञ्जीथाः मा गृध कस्यचिद्धनम् ॐ भूर्भुवस्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो न प्रचोदयात् सर्वेऽपि सुखिनः सन्तु सर्वे सन्तु निरामयाः सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखमाप्नुयात् द्यौ शान्तिः अन्तरिक्षशान्तिः आपशान्तिः औषधयशान्तिः वनस्पतयशान्तिः विश्वेदेवाशान्तिः ब्रह्मशान्तिः सर्वशान्तिः शान्तिरेव शान्तिः सामा शान्तिरेधि ॐ शान्ति शान्ति शान्तिः
Thank you everyone. Please be seated. Any institute can probably be recognized by the person who sits at the head of its academic chair. And we are lucky to have Dr. Deepa Nair as a principal, a keen academician, and again I would like to inform you, madam, that she has passionately and efficiently been the head of the medical education unit as well. So we are lucky, and that's why institutes like ours believe and go ahead with such programs. It's time to hear the welcome address from our principal, Dr. Deepa Nair.
Thank you, Dr. Sushma, for the kind introduction. A very good morning to respected dignitaries on and off the dais, and warm welcome to 13th Annual Research Conference of MAIR MIT Pune's MIMER Medical College and Dr. BSTR Hospital, Talegaon, Dabade. We organized our first Annual Research Conference in the year 2012 with the Department of Surgery and Microbiology being the organizing departments. Since then, we have been organizing it every year, except in 2019, when we could not organize because of the COVID-19 pandemic. And since then, we have been organizing in hybrid mode. The theme of our 13th Annual Research Conference is Mind, Movement, and Medication, an integrated approach to healing. So I congratulate the organizing departments, Department of Psychiatry, Orthopedics, and Pharmacology, for selecting a very relevant theme. They have thoughtfully selected the theme which involves area of interest, focuses on holistic framework of managing health conditions. So the mind, movement, and medication are the three pillars which work together in the integrated approach of healing. So the mind component focuses on the connection between the physical health and the psychological well-being, whereas the movement focuses on the physical activity as well as the physical rehabilitation, whereas the medication is the pharmacological intervention required to treat the symptoms as well as the underlying health conditions. So recognizing the deep connection between the mind and body is important to reduce stress and manage various conditions, for example, chronic pain, and thereby enhancing the overall well-being. So in addition to the faculty and PG residents, the UG students also get an opportunity to hear the eminent speakers and as well as to present their research paper in the conference. So we know that the medical field is very rapidly evolving, and it's very important to stay current and get updated. So on behalf of MIRE MIT Pune's MIMER Medical College and Dr. BSTR Hospital, I extend a warm welcome to our chief guest and keynote speaker, Dr. Heenal Shah, Professor and HOD, Department of Psychiatry, Topiwala National Medical College, Mumbai. Welcome, ma'am, to this inaugural function. And a warm welcome to the guest speakers who were there in the morning. And also a very warm welcome to our own executive directors, Dr. Sujitra Nagre, ma'am, Dr. Viren Gaisa, sir, and our medical superintendent, Dr. Darpan Maheshwari, sir. And a warm welcome to our MMC observer, Dr. Nandakishore Mantri. So I also extend a very warm welcome to the judges for the paper and poster presentations, and also all the delegates of this conference. So hope this two-day conference provides a new insight into the holistic approach of healing. So looking forward to an academic feast. Thank you.
Thank you so much, ma'am, for that heartfelt welcome address. It's an absolute privilege for me to be able to introduce our chief guest for today, Dr. Heenal Shah. Madam is professor at TNMC and Nair Charitable Hospital, Mumbai. She obtained her MD degree from KM Hospital, Mumbai. She has a MSc in medical education from the University of Maastricht in the Netherlands. Madam has several achievements, but just to name a few, she received the St. Vincent Thomas Tour Fund for development of a skill-based fellowship training program in child and adolescent psychiatry in Mumbai. We have been joined by our other executive director, Dr. Virendra Gaisa, sir, a renowned rhinoplasty surgeon across the globe. And also, madam, we are lucky to have such executive directors. He is also author of an international reputed book on rhinoplasty. Welcome to the dais, sir. So again, a little small glimpse into madam's achievement continues. Madam has received the International Fellowship for Medical Education, IFME, as we all know it, from Feimer, Philadelphia. It really warms our hearts as medical teachers, ma'am, to have a chief guest who's so passionate and so decorated with medical education degrees. We are really privileged to have you as a chief guest and keynote speaker today, ma'am. She has been the recipient of the Savitribai Phule Award for Excellence in Work and Contribution to Health Services of Municipal Corporation of Greater Mumbai, which was bestowed upon her by the mayor. She has had the privilege, and the audience has been also lucky to have heard her several orations. Just to mention a few notable ones are the Dr. L.P. Shah oration, Dr. S.M. Lula oration, CEO oration, and many such. She also has held several and continues to hold some important posts in the professional bodies. Madam has been the past president of the Bombay Psychiatric Society. She is on the research committee of the Indian Psychiatry Society. Madam holds the chair and the post of treasurer in the Indian Association for Child and Adolescent Mental Health. Of the research areas, she is a very keen researcher, has several publications to her credit. Her special areas of interest are child and adolescent psychiatry and medical education. May I now request our Executive Director, Dr. Suchitra Nagre, Madam, to please felicitate our Chief Guest, Dr. Heenal Shah. Thank you so much for coming, ma'am. And we all Really delighted to have you with us today. Thank you so much, ma'am. Another tradition deeply rooted in our Indian values is the lighting of a lamp, the symbolic lamp which signifies knowledge, and we pray to the Almighty and to the gods of wisdom and knowledge to dispel all the darkness of ignorance and fill us with knowledge. May I request all the dignitaries to please proceed with the lighting of the traditional lamp. Thank you, dear dignitaries. Thank you, dear dignitaries. May I request you to please be seated. It's time now to release the souvenir. Shah Madam, the souvenir committee painstakingly puts together the abstracts of all the posters and the papers which are presented here, along with a few other articles in the form of a souvenir dedicated to this conference. May I request the dignitaries on the dais to please officially release the souvenir for the 13th Annual Research Conference 2025. Thank you so much, dignitaries on the dais. Our executive director, Dr. Virendra Ghaisas, probably is a person who has led by example, who himself hosts the international rhinoplasty workshops endlessly and tirelessly with his team, and that is what somewhere motivates us to hold such kind of conferences. May I please request you to I think everyone is equally waiting to hear you. Sir has just rushed here right out of the OT, so probably he needs a breath of respite, but we'd love to hear from you, sir.
Thank you, Sushma. Dear Suchitra, Principal Madam, our guest, Dr. Shah, our all colleagues. I'm not really keen in talking today because I'm here to listen to what Madam has to say and all the speakers has to say. I think congratulations to Ganesh and I think all the entire team for organizing such a great event, great conference. As a clinician, as a doctor, as a parent, I think we require all this, and this subject touches you in all aspects. So I really don't want to stand in between the lecture of keynote address of Dr. Shah. So again, congratulations for organizing a great conference. And what I will say, we are doing this conference consistently. This is our 10th annual conference, and it should grow larger and larger. So best wishes again, and thank you so much.
Thank you so much, sir. We, the faculty of MIMER, will make sure to carry forward what you have put in today, that to make the conferences bigger and better. Now, without any further ado, may I please request our chief guest, Dr. Hinal Shah, to deliver the keynote address. We are all eager to hear from you, ma'am.
Good afternoon. It gives me great pleasure to be here. My first visit to MIMER. I had, of course, heard about it and known about it. This time, a colleague of mine, Dr. Dhananjay, rang me up before even Dr. Avinash could ring me up, telling me that please come to MIMER. And I thought this was a brilliant opportunity to come and visit the place which I've heard about. And of course, it was wonderful to hear and see. I've been around a bit, and including the Department of Psychiatry, which I was most interested in, and the temple. Thank you for having me here. And it was so interesting to note your theme. You know, you talked about the 3 M's, movement, mind, and medication. So I thought it was a wonderful way of going ahead. And then I was asked to speak on neuroplasticity and resilience, both of which will make or break us. So it's wonderful that I'm allowed here to be here, and thank you for having me here. So I guess I go back to say that people will have thought of asking me to come here because of our work in this field, especially in the work of children. We have a very strong child psychiatry department in Nair Hospital. And about in 2023, we inaugurated, the Chief Minister came to inaugurate Early Intervention and Rehabilitation Center for Children, which is a 5-story building which is under establishment of Nair for any child which has any disability, whether it is physical, mental, but there is early intervention and rehabilitation. And I think there is where this confluence of mind, body, and resilience really comes into play. So the experience of that also brings me to this topic. All of us have heard of Helen Keller. She lost her sight, lost her hearing. But wow, she achieved much. And one of the things that helped her is that touch took over. And what is that an example of? How did touch take over what we normally do? You're all nodding, reading, hearing. But if you could not read and you could not hear, how would touch take over? And this is how the training helped her. And this training is an example of neuroplasticity. So we are talking about how cross-modal plasticity can occur in a brain. And the lesson for resilience is that if it's profound disability also, it need not impair you. The brain can function if it's persistently stimulated. So what is neuroplasticity? What is it? All right. It's of the capacity of the brain to change its structure, its function and connectivity in response to either an internal or an external stimuli. So you can have a stimuli in terms of injury, learning, experience, stress. And in the past, we believed that neuroplasticity was at childhood, which is a fact. Maximum neuroplasticity happens in childhood. But the good part is it doesn't end there. So even at whatever age you are, the brain can yet respond. And therefore, even trying for a person who's 60 and has a stroke or has some other problems or learning a new thing at 60, it can happen because the brain doesn't stop being neuroplastic. And then how is resilience connected to all of this? How do we join this neuroplasticity and resilience? How do we marry them? Well, neuroplasticity is one thing which also recovers from injury, but resilience against cognitive decline is also because of neuroplasticity. So when there are adaptive changes, we can learn a skill, we can learn new things, we can rehabilitate, and we can have healthy aging. When it is maladaptive, because in life everything is good and bad, it's always a struggle and a bounce. So if it is maladaptive, the process can entrench pathologies such as chronic pain, addictions, and psychiatric conditions. So harking back to physiology and anatomy, because our principle also comes from physiology, neuroplasticity happens because of synaptic, structural, neurogenesis, and functional reorganization. Keep stimulating and neurons will increase, the number of receptors will increase, the number of chemicals released will increase. So you can learn. And of course, when it's maladaptive, it causes problems. You decrease the number of stimulations, and that is how you can also help in pruning. So there is both increase in stimulation and decrease in stimulation that can cause changes. And then there is structural plasticity, the connections. Eventually, it's all about connections. Bombay has become an example of connections. Coastal road, metro, railways, bridges, the connections make things go faster. And newer connections, problems along the way, but eventually connections help. So similarly, newer networks, connections in the brain will help in, because the brain is plastic and allow all of this, will help in better communication within the brain. And eventually, birth of new neurons. So all this helps us. And what increases all this? How can I make my brain work better? How can I remember better? How can I learn better? How can my children do better? All these questions that keep coming in our mind. Exercise, environment which stimulates. There are, of course, drugs that have come up. There is experimental gene therapies. And when this is going well, a good mood, stress, resilience, and cognition improves. Unfortunately, if you're forever stressed and our cortisol goes high because of that chronic stress, plasticity goes down and so does our resilience. So this was just an example, how a motor person getting a stroke, you do constraint induced movement therapies and the other hand learns. What's this an example of? In India, we are passionate. Even if Messi came and there was a crowd everywhere, they're yet passionate about cricket. Right? That's number one yet. What is this an example of? I would think resilience. If you knew the fastest man in the world is coming and bowling to you and at that speed and some Yorkers and you stand there and you hit and sometimes hit a six, it's resilience, right? So what is resilience? What do you think is resilience? Being strong, okay. What else is resilience? Surviving adversities. Is it only surviving? Flourishing, right? So it's not just surviving, it's flourishing. So it's that part of the brain and behavior which gives us the capacity to withstand, adapt, recover, whether it is physical or psychological. And we are hoping that just returning to baseline is not what we are looking for. We are looking for being better. And therefore we all want to be the BPC, the bounce back champions, right? We want to bounce back and we want to bounce back higher. The oak fought the wind and was broken. The willow bent when it must and survived. So sometimes we have to bend. What do you think? Resilience is physical or it is psychological? It is given by nature or it is nurtured? Both. That's the safest answer. Well, yes, it is both. Okay? It is both because both the genes, your environment, your upbringing all make a difference. And we'll talk about examples of that. So there was this young person who had a post-traumatic stress disorder because after a severe traffic accident, he kept experiencing and reliving that whole trauma. So what is happening in the brain? Like there is overactivation of the amygdala. The memories keep coming and again. There is reduced prefrontal cortex, which actually puts the brake all the time. Na? Brake lagana chahiye. Wo brake nahi ho raha hai. So that's why it's happening again and again. And there is a impaired hippocampal, which is contextual memory, so it's coming again and again. So we give treatment, whether we give medications and we give therapy, and the person is better. So what has happened? How has the brain changed? So repeated exposure to that trauma-inducing event has helped to weaken the fear circuit in the amygdala. The therapy and the medication has affected the prefrontal and the limbic. Prefrontal is the brake, limbic is emotional. So getting those brakes and strengthening the brakes helps in the emotional regulation, right? The hippocampus reorganizes and the traumatic memories are then integrated rather than becoming re-experienced, okay? So we are saying that medication and therapy changes the brain, right? And this is not what we are saying. It is also seen in enough imaging, whether it is MRIs or PETs or, DSAs, whatever you are seeing now, we are seeing these changes happening. So the resilience is that the individual learns coping, gives a new meaning to that event that happened, and learns to control his or her life. Fear decreases, confidence increases, adapts and grows beyond it. So psychological resilience is not just that talking and we got rid of it, but we reorganize the brain for recovery, adaptation, and newer functioning. And I won't go into this. Everybody in medicine knows about this. That there is one, the hippocampus and the ACTH and the steroids, but also there are so many models of transgenic mice and others where, you separate the baby from the mother and you're inducing stress. Horrible experiments, but which help us to tell us how the brain rewires and how it learns and what can help in getting them to be resilient. So should we blame it on the environment? Kya kare? Today I was supposed to come here and sir was very worried. What time will you leave? He didn't want this to be late. So I said, my Google map is saying 2 hours, 40 minutes. He's saying, no, it sometimes takes 6 hours. And sir was telling me that last time the examiner took 6 hours to come. So should we blame it on the environment? Our environment has changed. Weather has changed. Bombay has cool weather, which never happened. So suddenly we have a cool weather and we have rains which lasted after the valley. So should we blame everything on the environment, or is it how we process the environment and our thinking that is important? So we have external stressors, and with that external stressors, we have neural mechanisms that are changing, physiological behavioral changes, and neuroadaptive changes in the brain. And that gives rise to how we behave, think, and do, whether we get angry or we adapt. So it's the genes, the early life environment, and the late life environment which are important in our responses. So while we may say that resilience is, coming back, what we want is that you come back and thrive. As Madam rightly put, we are hoping that all of us are in this zone. All right? And how do we get into that zone? So I've given the theoretical background, but how do we get there? Of course, this is the brains and the areas involved. Again, I won't get into that, but this just shows that there is evidence for all of this. Think of a time when things went badly at your workplace. There were adverse circumstances. Even then, your HOD, your leader, or you succeeded in moving ahead. What happened? What characteristics helped him or her to move forward? And this is going to be interactive. And it's not going to be only these three women, very smart ladies, but all those people over there who are going to answer. So think for a moment, and anybody can answer, what characteristics of a person that you saw which helped that person to move ahead? Yep. There, madam is offering. Thank you.
Persistence.
Superb. Persistence. Yep.
Patience.
Patience. Sir is saying something. Okay. Patience. Very good.
Communicating with the team and taking feedback and then making changes accordingly.
All right. So communicating with the team. Positive attitude, yes, the vice principal is saying keeping a positive attitude is equally important. So, first and foremost is being able to look at reality. Sach kya hai? All right? Positive views of the future, commitment to your values. It's such an important thing that you have your own personal values and you're committed to it. Belief that you can do it. Investing your energy well and courage to act on your convictions. So I'm going to just describe a model which is from this book, which talks of the 6 P's. Purpose, perspective, partnership, proactivity, practice, and presence. And I've added a 7th P, because I believe a personal values are as important as all those 6 P's. He who has a why to live for can bear almost any how. And I'm now moving to talk about when we have stress, how we can improve and how this stress can cause changes in the brain and resilience can come out of it if we work to it. So just think about one thing that you're passionate about your work. All of you all are passionate, otherwise you wouldn't be here. Something that you enjoy and gives you satisfaction. What is being served by your work? Why are you doing this task? Why are you happy traveling 40 kilometers, 20 kilometers? Because I believe quite a few of the crowd comes from Pune. So you're traveling 20 to 40 kilometers. Why are you happy doing this work? What is the connection between the who and why? What are you doing? Like, I'll give you an example. So people often ask me, why aren't you starting practice? And I stuck to being in BMC hospital. So for me, I felt that I love teaching and I like research and I like serving the community. And I feel that, when you're working and there is so much administration, there are some problems or the other. Aaj ye nahi aaya server, aaj medicine khatam ho gaya hai, there's an RTI to answer, the dean has called you. I mean, there are multiple things that are going on in life. So why are you yet here? So one thing that I do is, I open the door of my OPD and I keep it open. So I can see smiling patients going back. I can see the work done by my residents. That is my connect to keep me happy. So what is that drives you? Let's hear somebody who has not spoken there. What drives you to do what you are doing today in Myanmar, one of the famous established institutes that is under MUHS? What drives you to be here, be a faculty? You should ignore all the principals and your leaders over there and say, what drives you to be here? For many it will be teaching, for some it will be convenience, for some it will be research, for some it will be service. But important is when there is stress, or in your daily life to manage the stress, remember your purpose. You may hesitate to mention it to me today in front of everyone, including your colleagues. But if you can remember your purpose, you can continue to work when things go bad. So, knowing your purpose, staying connected to that purpose. So you have to also think, A, what is my purpose? How do I keep reminding myself what is the purpose? Two important things that will help you to fight stress. Be a lamp, be a lifeboat, be a ladder, help someone's soul heal today. Walk out of your house like a shepherd. And that's the purpose of some person. Everyone has to have a purpose. If you think you don't have one, think again. Search your soul, search your mind, and you'll find your purpose. All right, so from one activity to another activity. And at this time, I'm going to ask for answers. Think of a difficult situation where, things didn't go well. You had a negative experience. You had a failure. How did you react to it? And how was your behavior for that? Somebody is going to share something that didn't go well, professionally, personally, small, big. How did you react and how did you behave? Who is going to be courageous enough to share? Anything. And they're students also, I believe, so I'm sure, failures, late assignments, all those things come into the play. Anybody wishing? Yeah, sure, ma'am.
Maybe that time my daughter was just 7-8 years old, and it is just, I thought I have to think about my daughter, about her future, and that is why with family and friends I could, you can say, Vijay Milavane, so that I could do. And that is what I would like to share with you.
If you, first of all, hand of applause for somebody to get up and answer. Ma'am, don't give away the mic. I'm going to speak to you. It's very difficult to stand up and talk in front of a whole audience and all the seniors. Ma'am, if I can ask a few questions. So when your health was not well, what did you feel and what did you think before you took your family into consideration?
See, basically, when I got to know about the diagnosis that time, it was a fear in my mind.
Yeah. And what did you behave? What did you do?
See, what I said, when that fear came to my mind, I said my daughter is just 7-8 years old and there is a huge life, her. My life, of course, I was thinking, but I was all the time concentrating that तिचं पुढे खूप मोठं आयुष्य
नाही पण तुम्ही केलं काय म्हणजे तुम्हाला मनात भीती वाटली तर तुमचं बिहेवियर काय राग आला काय केलं तुम्ही बिफोर यू थॉट ऑफ ऑल ऑफ दिस फर्स्ट रिएक्शन्स काय होते
भीती वाटली दॅट वॉज फॉर जस्ट फ्यू डेज यू कॅन से बट देन सारखा मुलीचा विचार असायचा डोक्यात सो आय सेड की इफ आय कीप माय सेल्फ पॉझिटिव्ह देन ओनली आय विल बी आउट ऑफ दिस आणि यातनं सगळं बरं होणार आहे हाच एक विचार माझ्या कायम डोक्यात असायचा
बरं झालंच आहे कारण आय कॅन सी यू ग्लोईंग हिअर सो थँक्यू फॉर शेअरिंग दॅट थँक्यू with students, right? We all go to students. Exams दिली, exams fail झाले, result चांगलं नाही आलं तर रडायला लागले मेरेल तर बरं and I rather kill myself, I don't want to live, or I start smoking and I start drinking. So what happens? Our reactions can be any of these. And we start worrying. But worrying is like a rocking chair, no? It gives you something to do, but it doesn't take you anywhere. So I'm going to ask you, look around, notice everything is blue. Blue seems to be the color of even Maya, but look around, everything that is blue, yes? Now, madam, tell me what is red? What is red? All right. So what happens? Our mind gets trained to look for what we want. If you train it to look for blue, it's negative, you will see only negative. So even if there are red flowers right across you, you may not notice it, right? So this was just an example how our mind deceives us. So our perspective matters. So I said we want to be bounce back champions. So we always begin with learning the ABC, right? Best way to start is the ABC. So what is the ABC? Madam's illness, consequence, fear. Failing in exams, consequence, attempt at suicide. But that's not what it is. Between the A and the C is the B, belief. Belief is what? Madam's belief was, मुलीचं पूर्ण आयुष्य आहे. आत्ता काय झालं तर काय होईल? That caused more fear than anything else. For the student, it was, how can I fail? मी केव्हाच फेल नाही झाला हवं. मेडिकलमध्ये आहो. फेल कसं होऊ शकते? Belief. So what actually causes all of this is not this event alone. It is how you interpret this event. Right? If that is the reason, then what will happen are ABC, which is the activating event, beliefs and consequences. The ABC that we need to remember has to change. So I'm giving you an example again. I have a presentation to make today in front of this class or this August gathering. And my thoughts could be, I'm going to mess it up. I will not speak well and I will be nervous and I will stammer and I will not talk properly and people will say, Bombay Sahibar bekkar kiya. And so I start getting anxious and I can't prepare properly and I try to look at it and I feel when I'm preparing my slides, jaane de yaar. I'm getting scared, anxious. So my body is getting racing and I'm hyperventilating. So I can do one thing will happen is that I start thinking people will feel I'm horrible, I'm not smart, aisa kaisa chief guest bulaya. And I get fear and I get palpitations and I can say I cannot come, I'm not feeling well, cancel kar do. And then if I cancel, I will tell myself, Arey, you could not give a speech also. So I'll feel sad and my body will react with decreased energy and I'll start avoiding people because if Dhananjay rings me up, Madam, tumhe ka nahi gele, kai zala? If Sir rings me up, what will I answer? And then I'll feel bad and I'll start thinking I'm no good at my job. And that makes me more stressed and has physical connotations and I then start checking. Okay, are people noticing me? Are they saying I'm no good? So all this because of our A, B and C and especially the B. So, you know, in summer we get a lot of ants in our house. Barabar na? Summer ali ki ants yete ki nahi? Similarly, all the time in our brain we get ants. They come without us knowing. They come in the periphery of our brain. We don't even realize this. And what are these ants? Automatic negative thoughts. Okay? Examples of automatic negative thoughts. People are always putting me down. I won't get this done on time, so let me not start only. Let me not go only to mimer. Anyway, I don't speak well. People don't listen to me. Nobody loves me. I'm a failure. I'm so annoying. All these are automatic negative thoughts. Kidhar se to aa jate hain? Gently they come in the brain without you knowing. If you know, then your prefrontal cortex would have got them out. But they slowly creep inside. And when they creep inside, they make you behave in a way that is harmful to you and the others. Your emotions, your body reacts like that. So our job is convert these ants to pets. And what are pets? Positive enhancing thoughts. तो ये कैसे हो सकता है? Ants को pets में कैसे convert करें? Patient outcome not good? Terrible. I can't stand it. I feel depressed and I go have a smoke and I can't sleep. Now, if you change that B, okay, patient outcome not good, that is bad. And I'm feeling horrible, but that's not end of the world. Let's see how I can retrieve the situation. So your emotions go down, come back, and you can continue to work and manage. So the ability to change your beliefs. Can we do it? Is it easy to do? It's tough. It's tough because our mind is used to thinking in a certain way. So it takes effort to change this. So one of them is changing your perspective. Because everything we hear is an opinion, not a fact. Everything we see is a perspective, not the truth. So we have to figure out, ये जो ants अंदर घूम रहे हैं ना, first of all look for them. Kitchen में तो हम साफ करते हैं ना, कोणता कोपऱ्यातून येते. You look properly with a magnifying glass and you put that Lakshman Rekha or you put that cement or whatever. Look for it in your brain also. Huh? See if those ants have entered. Find them, stop them, question them, put brakes on them, and change them. And to do this, first of all, you need time to think. Arey, 40 kilometers I have to travel to come here, twice a day. Where's the time to think? Find the time to think. It takes a few minutes. It's for yourself and your mind. Find those 5 minutes to think. Because unless you reflect, you don't realize. If you don't realize, you can't change. And you have to examine reality. Aaj kya hua? What actually was wrong in that situation? Be flexible and creative in your thinking. Nahi, me asat sangte. Yeah, okay, very good. Asas, but you have to sometimes think differently, have a wider perspective. Challenge your negative thinking and be more reasonable in your thinking. Put on your perspectives. In desperate times, much more than anything else, folks need perspective. For perspective brings calm. Calm leads to clear thinking. Clear thinking yields new ideas, and ideas produce the bloom of an answer. Keep your head and heart clear. Perspective can just as easily be lost as it can be found. So finding the time to look and getting a perspective is extremely important. And from there, we come to partnership. We always feel we are the greatest. Main hu na. But hum hai na is more important. For resilient people, building trust, managing expectations, including people having communications and craving for feedback. All the things that you all mentioned is important. Madam is from Kerala. Brilliant example of partnership. Right? This whole race is just about partnership. So having the right people together in the team makes the biggest difference. Eventually, proactivity. It's not going to happen. अपने आप नहीं होने वाला है. You have to work on it. And you have to also accept. Some things can be changed, some things can't. So accept what is, let go of what was, and have faith in what will be. So if you want to be resilient, you have to stay in action, know your values, follow them. Have a good team, adopt long-term thinking. वो short-term gratification आज और अभी is good, but you also have to think long-term. Be a great listener. Only if you're listening and you're aware, you know what is going on. And listen even to yourself and your internal thoughts. So for each of us, when we are alone, to think in my circumstances, what is it that I have to accept and what is it that I can change and I have not done anything about? इसमें क्या हो रहा है? What is happening here? You can see a big elephant chained to a small rope. You think that rope and nail can actually keep the elephant in place. But when we used to go to the circus, when there were circuses in our days, it used to be like this. Why was the elephant not trying to break? He has learned that. Because जब वो छोटा नन्ना बच्चा था, they tied him up. He tried and tried, could not break free. So he gave up. And that happens with us. We may fail once, we may fail twice, and then we give up. So beware, don't give up. Learn to be more proactive. And then, of course, I failed in the exam. अरे external खडूस, वो हीनल मैडम आई थी बॉम्बे से, इतना बेकार सब फेल हो गए. Not my problem. Problem is in the world. Therefore, I am not doing well. So beware of this external control. मेरा problem है ही नहीं, problem बाहर का है. So we have to be more aware and take the locus of control within it. What is it in my circumstances I can change? As Stephen Covey, if you've read that book, talks of 7 habits, of successful people. Spend more time on what you can control, then automatically what you can control will increase. And for the last few minutes, surround yourself with positivity. Write things in a diary, notebook, apps, whatever. Keep a gratitude journal. Look after your physical health too. A mental health requires a healthy body also. Relax. They're necessities. Have fun. What is it that I do on a regular basis that is restorative? As each one of us doing something that helps us to be physically and mentally better. If not, we can start now. Even our brain is neuroplastic. We can yet become resilient. And they have shown, enough research has shown that sense of presence, that is in a crisis, being able to decide what to do can be learned. And which are the things which help? All these, from our own yoga to Tai Chi to mindfulness, all of these help in creating that sense of presence. And that creates resiliency. And of course, I'm not taking it back to connect it to the brain, but all of this creates changes in the brain. Finally, I've just mentioned 3 anything as personal values, but each of us has our own personal values. Being able to have those values and being connected to them is most important. So eventually, this model for resilience talks of purpose, have a sense of purpose, stay connected, have a wider perspective, partner with people. Hum Hu Na doesn't work. It works for Shah Rukh Khan. For us, we have to be a team. Be proactive, practice, have a sense of presence, and be connected to your personal values. And the last slide. Like I said, all synaptic plasticity, neuronal plasticity, reorganization. It can be adaptive, maladaptive, and what is the current intervention based on this? So we have cognitive training programs, we have pharmacological modulators, pharmac, we have gene therapy approaches, we have lifestyle interventions. We have both movement, mind, and medication, which can help in all of this. And emerging technologies in neuroplasticity, right? Brain-computer interface. We have TDCS, RTMS, we have epigenetics, which is now coming in the future, which will connect so much of this, and advanced neuroimaging. And what is the level of evidence? Eventually, this is a research program. So I cannot end by telling you what is the level of evidence for all of this. For things like transcranial, magnetic stimulation, the level of evidence for depression, stroke, pain is moderate. TDCS for cognitive enhancement, stroke, moderate. Similarly, BDNF drugs for depression, cognitive resilience, moderate. Brain-computer interface for ALS, stroke, moderate. Cognitive training, moderate. Of course, emerging for gene therapy, all the CRISPR and all of those that are coming. In the next few years, hopefully, we'll have evidence for all of that. AI-assisted, emerging. I urge everybody. AI is today and tomorrow. I think it should begin teaching in schools. And if it has not, it should start beginning in medical education. AI may decrease some of our work, but if we know AI, we'll be able to use it much better. So for all medical teachers, you have to be knowing AI, all right? And finally, neurogenesis, there is moderate work that is evidence for all of that. So with this, I end by saying, make a plan for yourself. What will you do in the next few months to stay firm in the path of resilience? I have given you a model. You can go look up more. I've talked about, the 6 and 7 Ps. But think about it. What will you do for your mind, your movement, so that you don't have to have medications, but your mind becomes resilient? Wishing you all the best so that you have a healthy body and a healthy mind. I'm open for questions.
Firstly, ma'am, thanks for the wonderful talk. I'm sure all of us are really enlightened. I have a friend who is in the US and he's a neurologist, and he says dance and music therapy. So I wanted you to enlighten us on what is the role of that. Is it improving plasticity at structural level, functional level?
Yeah, so there is a lot of work that has been done on all these complementary art, music, therapies. In fact, in our early intervention center also, we are now getting aqua therapy. We already have a gait analysis, and we are getting art, animal-assisted therapy. So there is a role of how art stimulates and causes neurogenesis, and that is the plastic brain which helps in connecting and rewiring. So these are the emerging therapies, and more work is coming out of that. And as I said, for some there is good evidence, for some there is moderate evidence, and some there is emerging evidence. But people all over the world are looking for answers where we were stuck for so many years. Thank you for bringing that.
Thank you, ma'am.
Ma'am, what we can do to increase the neuroplasticity and resilience in children? And I have a son who is in 7th standard, so what I can do?
Some of the things are similar, but I think parenting is a very big thing in resilient children. This whole world talks about be a friend. I'm not saying don't be a friend, but be a parent first. They can find millions of friends, but you have your responsibility as a parent. So one is be a good parent, lay down the discipline. Second, the world is all about instant gratification. Everything happens, I want it, I get it, I order it on Blinkit, it comes in 7 minutes and I've got it. I want something, it is done. The world is moving too much for early gratification. So if I don't get it immediately, I can't deal with it. So teaching them delayed gratification. मेहनत करके, we say patience का फल, सब्र का फल अच्छा रहता है, मीठा रहता है. That attitude has to come also. Third, I think people are getting so involved with social media, which has its wonderful world, but this digital addiction and becoming lonely is really, really coming up. Loneliness is a big thing. And then they don't learn how to interact and network with people. They don't learn, when you go to a playground and play, you learn to lose, you learn to win, you learn to work in a team, you learn to help others. All that doesn't happen when you are on the phone. So at least a few simple things which we can do is create a balance of learning them to learn, social interactions, play, discipline, and no immediate gratification. A few tips that I could give off the cuff.
Thank you, ma'am.
Ma'am, I have two questions. First is all these anxiety issues or depression issues in earlier generation. आमच्या वेळेला असं काही नव्हतं हे तुम्ही उगाच काहीतरी वाढवलंय. It's a typical sentence our parents will tell us. So is it really true, or now we are more aware? That time also there was some issues. So that is my first question. And the second question is, again, everyone is saying no poor people will have all these things. It's a again a issue of rich people. So is it really true statistically, or it's a fact that it was not there in previous generation?
So starting with the first question, there is a book, Anxious Generation. I don't know if you've read it, you must get it and read it. That this whole generation has become more anxious. I think circumstances have changed and you can't deny it, they're more anxious. If we see them in our clinics, if we see them in our classes, if we see them outside, definitely that anxiety is much higher. For whatever reasons, whether it is the environmental changes, social changes, economic changes, there is definitely higher anxiety. Maybe the demands are different, but there is higher anxiety. And evidence says that anxiety occurs across all countries, across all situations, across all socioeconomic status. What you may be anxious about may be different. You may be anxious for your next meal, or you may be anxious for your next car. But anxiety and anxiety disorder, this is just anxiety, but anxiety disorder also occurs across all spectrums, all right, of socioeconomic status. Even depression occurs across all socioeconomic status. Maybe depression occurs more in women, but that doesn't mean it doesn't occur in men. So it's happening everywhere. It is not a new fangled idea. Maybe we have had different parenting that is happening now. Maybe the world of social media, how many likes have I got? You know, all that is changing. So definitely it is happening more. But those are very relevant questions because I get these questions all the time. Is it a new fangled idea? Okay, you know, anxiety is high, but it is high. All right, so I take my leave. Thank you once.
Thank you so much, ma'am. What a fabulous keynote address. I think that applause says it all. And I could see the audience mesmerized and listening to you, every word that you were speaking from there, and I could see them hunting for the ants in their mind and brain, and I'm sure they'll try to make them into pets. I hope there aren't too many leave applications increasing now in Mimar to sit and think about ourselves. Just fantastic, ma'am, and we could see the passionate teacher in you also. Your students are really lucky, I must say that. And I think we learned so much from that short keynote address that we heard. I think they'll make us into better people, better doctors, better parents, better wives, and so on. Now it's time to listen to our great leader, because of whom probably, if I want to pin this down to one person because of whom such activities happen in this institute, it is our Executive Director, Dr. Suchitra Nagre, Madam, who takes personal interest in every great detail, and probably she was the most attentive listener right now. I'm sure Madam must have made notes also, as much as I know her over the years. So that is the kind of leadership we are lucky to have in this institute. And may I request ma'am to please share a few thoughts with us on this occasion.
Thank you, Sushma, for those kind words. A warm good afternoon, I'll say, to all sitting here. And let us applaud one more time for our chief guest today. Thank you, Anish, and Mr. Dhananjay, or Dr. Dhananjay, Madam was referring, for suggesting ma'am's name, and she could make it all the way. Thank you for not cancelling today's program, I will say. I'm so happy that this 13th Annual Research Society Conference has taken up a shape which we were expecting few years ago, that how a research conference should be conducted in Mimar Medical College. And when I was listening to ma'am, I think every one of us, when we were listening to her, we were going back to all the incidences happen in our life, in our day-to-day life, in workplace or home or I'll say, even outside world. And when she was asking questions, I think everyone was having something on their mind, but few could raise their hands and speak. So, but I'm sure that with all her inputs on the topic of today's conference, we have got almost all answers, ma'am. Thank you so much for that. And when she was talking about resilience, I was just remembering all our NMC inspections over the years. And I always remember Dr. Sontakke ma'am, because once we failed, we did good in the inspection and we failed. And I was crying in my office. So she just came, our ex-principal, Dr. Alka Sontakke, she was a biochemistry professor, very research-oriented lady. She just came to me and she said, see, we cannot keep crying. You have to stand up again and we have to face it one more time, that's it. And even for a few other things, you know, I have learned in administration in last 20 years that every day you can have a new lesson to learn. And for that, no need to be in administration full time. We all of us learn something every day from the people around us, the situations coming to our lives. And then I was just wondering when she asked about resilience, I was thinking that, okay, when we go wrong, we should take a pause and introspect where we had gone wrong rather than blaming the situation or the person or someone else. Rather than that, just introspect, take a pause and restart again. I think that is the way. We don't have any other choice. We can't quit when something goes wrong in families or some bad incidents happen. We can't quit, right? And restart. There is no third option available, I always feel. Whenever I was telling ma'am that Dr. Karad and Dr. Ghaisas, Sir Viren's father, Sir used to come to this institution every day till he became 80 years of his age. And after that, he was coming alternate days. So thanks to all our parents and the founders of MIT Group of Institutions that they have given us such a platform where we can stand and we can create leaders and we can have such kind of healthy discussions. Few years ago, maybe people used to think that why someone should speak openly about depression or anxiety or any other diseases or problems of psychiatry especially. But thanks to all the film stars and the media that people are talking openly, but as Viren rightly questioned that is it true or just for small reasons also the people are going to psychiatrician. I'm not sure about anything. But every one of us need help at some point of time, and we should ask and seek for help in every status, I feel. So congratulations to all the people. Today morning I was listening to the morning lectures sitting in my cabin because I was little late to come to Myanmar. So I listened to Dr. Arjun and the madam from Bharati Vidyapit. And I'm so happy that whatever thought process was there behind starting this event 13 years ago or 14 years ago had shaped so well, and I'm sure with all my faculty and PGs and undergraduate students, we'll take this Research Society Conference event to greater heights every year with an apt theme. So thank you Dr. Ganesh, Anish and Dr. Borkar sir for choosing such a wonderful theme. Whenever it comes to speaking about mind, I always remember my father, Dr. Vishwanath Karad, who keeps saying we should and we must understand the chemistry of mind, right? And the connection of mind with the brain. He keeps speaking about it, and I'm so lucky that I have heard him over last 40, 50 years from my childhood, and he keeps telling us that whenever you are in wrong status or wrong mind of state, just wait. And a good leader like Dr. Ghaisas and Karad sir and Joshi sir and all our founder members, they have never criticized when we went wrong, the second generation. They have always said, okay, fine, you have gone wrong. You can do it better next time, and this is the way you can get it done. Similarly, I think it's our responsibility now of second generation, and now the third generation is coming into picture, to take this legacy of the education across the globe. I'm so proud that our fifth university, which I used to keep saying last year that Solapur will come up. We have opened 5 universities across India, and with God's grace, if possible, Mimar should be a university soon, I feel, to have more freedom of academics and research, because when we go back to the state university, there are some rules and regulations which are and speaking about research in India, it is always, we are just doing few % of it, I'll say. When we look at the global research, we are at very basal level, but still giving a try with all our capacity is more important than not trying to do anything. So let us pledge today that we'll go on doing our best at Mimar Medical College. Ma'am, I would like to tell you that we are one of the most famous institution, I'll say, which is attached to MUHS, and I'm so proud that all my UG students literally could get the PGs in first instance through open category, and all the credit goes to my teachers who groom them and who make them a holistic doctor. Thanks that we are in the rural area of Pune, which gives them the glimpse of rural and the city environment, I'll say, because they belong to different families and different backgrounds, but when they come to this institution, they all are same and they are treated equally by all my faculty, and they get to learn from the great teachers. I'm so proud that so many people are here since the inception of this institution, and all the credit goes to Ghaisa sir and Karad sir and their preachings which they have given to us throughout these years. So I'm so happy that all are here, and even tomorrow it will be a wonderful panel discussion and lectures, and the afternoon session will be equally great for all the paper presentation by UGs, PGs and faculty. So once again, I welcome you, ma'am, for this event of mind movement medication. So let us stay active, keep our mind calm, and medication can stay away from us, but we'll keep teaching medicine. Thank you so much.
Ma'am, another sign of a great leader, passing on all the credit to her faculty. We love being teachers here. That's one of the answers, ma'am, to why we travel so many kilometers every day. Thank you so much, ma'am, and amen to that wish of us becoming a university real soon. It's now time to hear from one of the organizing chairpersons, Professor and Head of Department of Pharmacology, Dr. Ganesh Pentewar. He'll give away the vote of thanks for this inaugural function.
Good afternoon, everyone present here. Respected dais, dignitaries on the dais, the honorable guest speaker, my faculty member, students, and dear delegates. It's my honor and privilege to propose a vote of thanks on this meaningful event, 13th Annual Research Conference 2025, organized by Department of Psychiatry, Orthopedic, and Pharmacology. This year's theme is the mind, movement, and medication. To get the integral approach towards healing, you should mind it. Any movement, take it easy, but take it. And for medication, if your meditation fails, then last source is for the medication. Okay. First of all, from the organizing committee members, I extend my heartfelt gratitude to our late Dr. Suresh Ghaisa sir for creating a synergy between the science and medical education. With the medical education and the academics with the research with the innovation, and the innovation and their impact on the healthcare service, so that every patient should get the affordable treatment. माइमर की चौकट से अभी तक कोई पेशेंट खाली हाथ गया नहीं और आगे कभी जाएगा नहीं. I extend my heartfelt gratitude
to Myers MIT Pune group of institution, our founder, president, Vishwadharmi, revered professor, respected Dr. Vishwanathji Karad sir, for their constant encouragement and visionary leadership. Sir has given one mantra from, but for the entire universe. Vishwa Shantir Dhurvam Dhurva means the peace which will prevail across the world. Vishwa Shantir Dhurvam Dhurva means ध्रुव ताऱ्यासारखं, ध्रुव तारे के जैसे विश्व में शांति स्थिर स्थायी शाश्वत और अटल बनी रहे. The science is for the world outside and the spirituality is the world inside. In the present scenario, just 2-3 days back, we have seen what happened in the Australia. So it's our firm belief which is given by this sir that the union of science and spirituality, religion alone will bring the peace to the mankind. Thank you very much, sir, for giving not only to the mimers but for the universe. I extend my gratitudes to our leaders, executive directors, the pillar of mimer, Dr. Suchitra Nagre madam, the internationally renowned rhinoplasty surgeon, Dr. Virendra Gaisa sir, for their continuous encouragement, for motivation, for mentorship, for guidance. I thank to our respected principal madam, Dr. Deepa Nair madam, and our meticulous but finely tuned medical superintendent, Dr. Darpan Mahesh Gauri sir, for providing all types of the valuable logistic support. I thanks to today's honorable guest speaker for taking time and became a part of this our event. I thanks to Dr. Arjun Dhawale sir for engaging and for thoughtful provoking for his presentation on the approach to the backache. And the sir's expertise has brought the new dimension for our understanding. Sir has given all the insight. फक्त एक दोन शब्दात सांगतो. आगे की सोच, पीछे की चिंता छोड़. Means forget about the back pain. आगे की सोच, physician, surgeon will take the care depending upon the, as sir has told, the type of pain, whether it is the leg dominant or the backache dominant. I thanks to Dr. Jayashree Daune madam for giving a very valuable insight about the pills, pain perception, that multidisciplinary approach therapy. Rational pharmacotherapy is a big topic. Madam's last slide. The science is for relieving the pain from the body, and the empathy is relieving the pain from the person. That is the what madam has given the message. I extend my thankful gratitude to respected Dr. Hinal Shah madam for madam's time and effort to crafting such a difficult topic, the neuroplasticity and resilience, the brain's role for the emotional and the physical healing. Madam has given a very important message that brain is not fixed. Brain is continuously evolving. Brain finds the new way. So madam, after your talk, everyone was stunned, everyone was hypnotized. You can see the spark in their eyes. Even I am thinking my college days in 1995, one very good serial, that Sailab serial. That one shairi written by the great Nida Fazli sir, singer, sung by Jagjit Singh, and the musician Tallat. लगता है We always think human beings, my brain cells, my ego, whatever it matter, whether it's the gray matter or the white matter. Okay, पहले हर चीज थी अपनी मगर अब लगता है. But within minute or within second, the life shatters. After the traumatic brain injury, or any emotional, physical, or the psychological traumatic injury, or the traumatic injury, the deadly diffuse axonal injury. Okay. But the brain always finds the new way. They compensate, they restore, they recoil, they rewire, and they nurture the resilience. Okay. So the next is the पहले हर चीज़ थी अपनी मगर अब लगता है अपने ही घर में किसी दूसरे घर के हम हैं. रुख हवाओं का जिधर का है उधर के हम हैं. अपनी मर्जी से कहाँ अपने सफ़र के हम हैं. Madam, the capacity of that neuroplasticity and resilience, we will ensure that we will apply to all the patients, not only in the recovering stage, but for the rediscovering their own, the strength, the independence and the positive potential. I thank to all the faculty members, our dear students and delegates, chairpersons, judges for their active participation. Your active participation and interaction, especially we have seen the interaction, academic interaction between the orthopedic and the anesthesia, whether to give spinal block or only for the non-pharmacological therapy. Okay. We ensure that the knowledge we have gained in today's conference, we will continue for the continuous learning and for serving our community for the better outcome. With this, I will end the vote of thanks. Thank you very much. Nandakishore Mantri, sir. Thank you, sir.
Thank you, Dr. Ganesh. Probably one of the most eloquent and stylish vote of thanks this premise has been witness to. Another tradition of this group of institute is to end the program with the Pasaidan, the last 9 verses of the Jnaneshwari, which prays for harmony and peace to descend on mankind. May I request everyone to please stand for the Pasaidan as we come to the end of the inaugural and keynote address ceremony.
These are our judges for today's session. We have our chairperson, Dr. Sandhya Kulkarni ma'am, Vice Principal and Professor, Department of Microbiology. Also, we have Dr. Smita Pawar ma'am, Professor and HOD Ophthalmology as our chairperson. We'll start with the presentations now. First presenter is Dr. Nilesh Jadhav. Instruction to all the presenters, you will have a warning bell at 6 minutes and there will be a final bell at the end of 7 minutes, followed by 2 minutes of question answer session.
Hello everyone, I am Dr. Nilesh Jadhav from the Department of Pathology, here to present a case series about histopathological features of calcinosis cutis. Calcinosis cutis, it refers to the deposition of insoluble calcium salts within the skin and subcutaneous tissue. It is broadly categorized into dystrophic, metastatic, iatrogenic and idiopathic types. The clinical presentation is heterogeneous and the underlying mechanisms vary across the subtypes. Accurate pathological evaluation is essential for distinguishing these forms and guiding appropriate management. Objectives of this study are to present the histopathological characteristics and highlight the distinguishing features between them. Nodules underwent clinical evaluation and excision. Histopathological examination was performed using H&E staining and von Kosa stains where as and where necessary to confirm the calcium deposition. Two cases involved long-standing asymptomatic scrotal nodules, while one case was a painful solitary heap lesion. All patients demonstrated no evidence of systemic disease or metabolic derangement. Histopathological findings: well-defined basophilic calcium deposits within the dermis in each of the cases. Surrounding tissue response varied from minimal fibrosis to a prominent foreign body giant cell reaction. No epidermal abnormalities were seen. So, analysis of all the three cases revealed consistent pattern in idiopathic calcinosis cutis characterized by dermal calcium deposits with varying tissue responses. First case was 56-year female, right hip swelling since 1 year. Second case was 36-year male, scrotal swelling since 12 years. And third case was 50-year male with scrotal swelling since 15 months. All the cases showed unremarkable epidermis, while dermis showed multiple well-circumscribed basophilic and crystalline deposits. While the third case was showed the presence of giant cell reaction, foreign body reaction, and inflammation. The second case showed presence of foreign body reaction only. According to this, the diagnosis was given as idiopathic calcinosis cutis in each case. First image of, this is the image of calcinosis cutis. Here we can see the unremarkable epidermis and multiple basophilic deposits of calcium in the dermis. This is a low power view of the same with unremarkable epidermis and calcium deposition. In this image, we can see the calcium deposition and along with the inflammatory response and giant cell. To conclude, calcinosis cutis encompasses a spectrum of lesions that require a systematic approach for accurate classification. Clinical evaluation, biochemical assessment, and detailed histopathology play complementary roles in differentiating idiopathic from secondary causes. Awareness of its varied presentations help prevent misdiagnosis, avoid unnecessary investigations, and guide appropriate therapeutic decisions. Further studies are needed to understand the pathogenesis better and explore targeted treatment modalities for calcinosis cutis. These are my references. Thank you.
Good afternoon.
There were 3 cases has been taken in
Yes.
this. So there are many types of calcinosis cutis. So was it any specific type of calcinosis cutis which
No,
was
ma'am.
selected?
There was actually no clinical evaluation done about calcium in the serum. Serum was not done, serum calcium levels.
Hmm.
So we named it as idiopathic.
Okay.
What are the secondary causes? You said it was idiopathic. What are the
Secondary causes were like this one. This dystrophic, metastatic, and iatrogenic.
No. Purpose of your study idiopathic and secondary causes, so that
Yes.
you can actually figure out in which they require further investigations. It
Yes.
can be a sign of some metastatic or something.
Yes.
So what are the other causes which can present with calcinosis cutis?
Causes like trauma and chronic diseases can present as calcinosis cutis.
Thank you, Dr. Nilesh. Do we have Dr. Prachiti here? Dr. Prachiti, ma'am. Okay. So our next presenter would be Dr. Prachiti Borkar.
So the title of my paper is Assessing the Effective Students, Implementation Strategies and Learner Perception. So I'll be talking in the following headings: introduction, objectives, methodology, results, discussion, conclusion, and finally the limitation and a further improvement. So NMC introduced pandemic module in the year 2020 in the MBBS UG curriculum. It was 80 hours of teaching spanned across all the phases of MBBS. Pharmacology covers only pandemic module 2.5, which includes the therapeutic strategies including new drug development. So the competencies addressed in this module is the student should be able to describe and discuss various phases of drug trials, prepare a plan for evaluation of and discuss the ethical aspects of clinical trials in pandemics. With this, our first objective is to assess the learning of module 2.5 in phase 2 MBBS students and to understand the students' perception regarding the implementation of the same. So it was one group, quasi-experimental, pre and post-test design. So the first we conducted pre-test using MCQs. Then the interactive theory sessions were conducted with the drug development, ethical aspects during the pandemic, off-label drug use during the pandemic, and pharmacovigilance activities in the pandemic. So after that, the formative assessment with the student seminar was carried out. Here the seminars were assessed by the 2 faculties using a presentation scale. Later, we also conducted a practical examination for the ADR to test their ADR reporting skills. Further, we conducted post-test same with the around 20 MCQs, and the student perceptions were recorded. About the statistical analysis, for the pre and post test, we did PET-T test. Similarly, for formative assessment also, we applied same test. Student feedback and OSPE marks were evaluated or analyzed using descriptive statistics. So this was the mean score of the pre and the post test. We hardly see any difference. This is mainly due to we covered in our MCQs the clinical drug development, which was covered already covered. So the robust MCQs needs to be developed. Moreover, the essay questions also required to evaluate that the knowledge gained. But we got good feedback almost they agreed about the faculty's role in teaching as well as using of audiovisual aids and meeting the requirements of the module. Further, they were also positive regarding their knowledge and skill development. Also, they agreed that the seminar which we did, formative assessment, very well captured, that they agreed that they could gain through that seminar, and the test also they found it very useful. Further, OSPI, they agreed that marks given to them was fair, and the testing was also fair. And they also agreed about the module that it should be taught to the all MBBS students, and it was very well coordinated. Again, this is the faculty scores for the student seminar. So we had students divided into 5 groups. So if you can see here, the faculty 1 score and 2 score we have shown in the table. For the group D and group E, there is a lot of discrepancy between the faculty scores. So we think that more better scale as well as faculty training is required in order to implement such seminar-based formative assessment. Lastly, this is the OSPI scores of the students. About 2 or 3 students only could get above 90%. 75, about 40% of students could get 75 to 90, and around 46% got 50 to 74% of marks. And less than 50, hardly any 10% of the students got. So there were no prior studies. This was the first study which we are reporting for the pandemic module 2.5. There are few studies like preparedness of undergraduate medical students to combat COVID-19. Here what they have done is safety precautions, contact tracing they had taught, and they showed a significant increase in knowledge and skill. Another study which was about the pandemic module but in the Department of Pharmacology, here also they only recorded the perceptions. This last study is also about the perceptions. So there are no studies which for the pharmacological pandemic module as well as involving the various assessment, formative assessments and other assessments. There are no reported studies. So even though we did not find much difference in the pre and post test, it was perceived positively by the students, and it was our first attempt, so we will definitely improve on the many aspects of it. So I think the limitations are it should be more robust, the pre and post test. Also we should include the essay questions only if we want to test the knowledge gain. It was again single institution study, so we have to include more institutions, and there was a difference between scores given by the faculty 1 and faculty 2. So that we need to train the faculty as well as we need to have the better scale for it. So these are my references.
First of all, good that you carried out this study for the first time for particular pandemic module.
Yeah.
But seeing your results, what I feel whenever you are doing the program evaluation, especially of such modules,
Yes.
Ideally you should first calculate the content validity index.
Yes.
Was that calculated?
Actually, content validity, we did it in-house expert. I think we should have gone for
No, that
other
is
institutes.
fine. What is content validity index?
Content validity, it should test what it should
No,
test.
it is basically I'm going in teaching
No,
mode.
it's okay.
Content validity is when whatever questionnaires you are preparing,
Yeah.
the number of the persons who are assessing that, how many of them are giving score more than 3 or 4 divided by the number of experts who are observing. So basically it tests how much the questionnaire is related. Because, it tells you the validity of questions. Because in pre-test and post-test, your scores are same. The reason given by you is that it was already covered in theory. Second thing is, whenever you are covering any topic in the theory and reinforcing it during your practicals, you can go with the questionnaire which are dealing with the higher components of knowledge. So it can be analysis, synthesis, like that. And you emphasized on theory, that's why OSPI scores were less. So the theory as well as the skill. So the speciality of any module is it covers maximum aspects. So whenever you are formulating the assessment, I think we should be more particular that exactly what part we are assessing and what tool we are using. So I can ask you to conduct the study with a better assessment.
Yes, definitely.
Thank you.
We learned.
Definitely, all the suggestions given by Madam are excellent. Along with that, what I feel, in addition to all above, that the faculty, the score was different. So you said that faculty should be trained. Rather than that, your assessment sheet given to the faculty should be uniform.
Object.
So that was objective as the seminar. That is for seminar. So for seminar, it was subjective assessment of the faculty. Now, objectivity should be brought to it so that it will again improve your studies outcome. Okay. Thank you.
The next presenter is Dr. Ashish from Department of Pharmacology.
Good afternoon, everyone. I am Dr. Ashish Dhanane from Department of Pharmacology. My topic is knowledge, attitude, and practices towards students, a cross-sectional study. First of all, antimicrobial resistance. According to WHO, when microbes do not like bacteria, fungi, viruses, and parasites, do not respond to the antimicrobial agents, it is called as antimicrobial resistance. It is microorganisms develop resistance to antimicrobial agents, making them less effective. Many microbes now exhibit resistance to standard treatment protocols. Irrational use of antimicrobials contributes to the resistance. Now, often physicians feel pressurized by the patients to prescribe of infectious diseases. More and more antimicrobial agents are used. Therefore, the incidence of antimicrobial resistance is increasing. There is a lack of awareness and adherence to guidelines among healthcare professionals, and there is significant gap between knowledge and attitude and practice about antimicrobial stewardship program among practicing doctors. The present study is due to there are very few Indian knowledge, attitude, practice studies of postgraduate resident about antimicrobial resistance. So the aim and objective to study knowledge, attitude, and practices about antibiotic usage and antimicrobial resistance among postgraduate students. Material and methods. Study setting and study population is postgraduate students of tertiary care hospital. Study design is cross-sectional, observational study, and sample size is 88, calculated by the formula 4PQ by L square, which was derived with the help of a statistician. The questionnaire was self-structured, that means a yes or no question. Validated, that means comparable questions from previous studies were taken. The questionnaire included a total of 15 questions, 5 questions of knowledge, 5 attitude, and 5 practice-based questions. So the data collection, a questionnaire-based cross-sectional observational study in the form of Google form, which was an online questionnaire was given. Participants were given information sheet and taken consent. Google form was provided to the postgraduate students. The field questionnaire was received from participants. All the data was analyzed by percentage method on Microsoft Excel 2021. So the results, out of 89 responses, one student did not consent. So total 88 participants consented to the study, and their data was included. In the demographics, most of the residents were 26-year-old, that is 18 residents were 26-year-old. Next is 16 residents were 27-year-old, and 14 each residents were 28 and 29 years old. Now coming to the gender, male participants were 46.6% and female were 53.4%. Coming to count of designation, JR1 were 36%, around 36%, JR3 were 39%, and JR2 were 24%. Coming to the questions, so knowledge-based 5 questions. About more than 94% participants correctly noted that indiscriminate use of antimicrobials leads to emergence of antimicrobial resistance, and effectiveness of treatment is reduced if full course of antimicrobial is not completed. Most of the participants knew that large doses of antimicrobials are not of better use for quick action. In the attitude-related patients to check the expiry date of antimicrobials before administration, and 70% were correct in saying that it is not always better to prescribe broad-spectrum antimicrobials. And 62% of residents knew that antimicrobials should be prescribed only after culture and sensitivity report. Coming to practice questions, so 87% of residents gave empirical antimicrobial therapy before receiving the culture results, and more than 92% of residents followed the ICMR guidelines and the hospital antibiogram for giving the antibiotics. And 75% did not agree correctly that discontinuing antimicrobials when symptoms disappear is wrong. In discussion, in our study, 90% of postgraduate students have good knowledge, which according to other studies in India, Malaysia, Portugal, Trinidad and Tobago, 95% of total respondents agreed that indiscriminate use of antimicrobial agents leads to development of bacterial resistance in consensus with Mahajan et al. Regular CMEs will make residents more updated and aware about antimicrobial resistance, and this study highlights good level of knowledge and attitude which match with good practice towards antibiotic usage and antibiotic resistance amongst postgraduate students. These are my references.
Good afternoon. Total 88 residents have been taken in the study.
Yes.
So all were from different branches, no?
Yeah, different
clinical,
branches.
paraclinical,
Yeah.
and clinical.
Yeah.
So do you expect that their knowledge will be same regarding antibiotics?
No.
So there will be some bias, no? So
Yes.
is there any measure to overcome that bias? Have you considered that bias, and have you done any statistical analysis to overcome that bias?
No, ma'am.
Same thing applies for JR1, JR2, JR3.
Yeah.
Their knowledge will be different. So when you are analyzing, ideally you should analyze them on the basis of how many JR1s, how many JR2s, and how many JR3s. So I think that is going to definitely influence the results, because JR1s are comparatively raw, and after seeing the patients or the gaining the knowledge, the results might be different.
I was going to write the limitation as cross-sectional studies, so their views may change over time. This is one time. conclusion is their knowledge and attitude matched with their practices, and they were sound in their knowledge.
Okay. Thank you.
Thank you, Dr. Ashish. Our next presenter is Dr. Kamalika ma'am from ENT.
Hello. Good afternoon, everyone. In the realm of medicine, it is often said that the eyes does not see what the mind does not know. This is particularly true for patients with nasal obstruction, where our focus on the deviated septum inadvertently often creates a diagnostic blind spot. Respected seniors and my dear friends, the topic of my presentation today is nasal valve dysfunction in patients with deviated nasal septum. Are we missing something? But nasal obstruction is multifactorial in etiology. The static causes, which are mostly anatomical, are the deviated nasal septum, turbinate hypertrophy, and concabulosa. The dynamic causes, which are those with changes with breathing, and they include the internal and the external nasal valve collapse along with rim valve collapse. The pictures are as is shown. Now, here is the structural component of the lateral nasal wall within which the nasal valve area lies, and as is apparent, these structures are very complex, the nasal aesthetics adding to the complexity. There is a lack of standardized evaluation techniques of this nasal valve area, and surgeries in this area are technically challenging. Hence, very often one only concentrates on the deviated septum and turbinate hypertrophy part. The aim of this study is to establish the necessity for routine assessment of nasal valve dysfunction in patients with nasal obstruction and to seek any relationship between deviated nasal septum and nasal valve dysfunction. So this was a retrospective observational study carried out in 43 patients with nasal obstruction during a period of 2 years, in whom convenience sampling method was used. Group A were those with DNS and Group B without DNS. In these patients, we also looked for the presence of concabulosa, turbinate hypertrophy, internal, external, nasal valve collapse, and rim valve collapse. However, patients who needed a revision or an aesthetic septorrhinoplasty, had septal perforations or nasal polyposis were excluded from the study. The clinical examination of the patient included dynamic assessment of the external nasal prolapse, nasal valve prolapse, and modified Cottel's test for the internal nasal valve prolapse. We supplemented this with endoscopy and the diagnostic and nasal endoscopy, and here we see a concabulosa, which is also seen in the CT scan finding a hypertrophy trophinate, along with we can see the internal and the external nasal valves. A CT-PNS is done. As is customary, a preoperative photography, which includes the left and the right lateral views, the profile views, the helicopter view, and the basal view of the patient. So when we tabulated the results of the patients with a deviated septum against those without deviated septum, we found that 88% of patients had internal nasal valve collapse in the deviated septum group in comparison to a 44% in those without DNS. Considering the external nasal valve collapse, 92% had deviated septum, external nasal valve collapse in the deviated septum group in comparison to 28%. So as we see this bar diagram, the red bars are much higher than the pink. These are the ones which are with the DNS, and as is seen in the upper and the lower lateral cartilage, they look quite taller. So when we tried to assess this with the chi-square test, wherein the relationship between the internal nasal valve collapse and presence or absence of DNS was seen, we found that the values were statistically significant. Hence, it suggested that internal nasal valve, similar was that with external nasal valve, and hence it was found that both internal nasal valve and external nasal valve had a significant statistical association with presence of DNS. So this is how we addressed our internal nasal valve collapse, Spreader's graft being used in images A and B, Eller-Batten graft being used in image C for external nasal valve collapse, and septoplasty for anterior caudal dislocation with a swing door technique being done in image D. So when we scouted the literature, we found that Wong and Bonaparte had suggested that the tools for diagnosing the nasal valve obstruction was inconsistent. They had suggested Cottles for external nasal valve prolapse and visual inspection supplemented with a modified Cottle for internal nasal valve prolapse. This confounds with our present study. Lee and Wong had postulated that identifying the epicenter and the mechanism of nasal valve dysfunction is crucial for appropriate surgical planning, which conforms to our present study. Ree et al. had concluded that nasal valve obstruction is best evaluated with physical and examination and history, which confounds with our present study. Green et al. Had also postulated that nasal valve collapse is an important concern for patients undergoing septoplasty with deviated nasal septum, and we cannot but agree more. However, Gagnier et al. Had suggested the use of rhinomanometry as a useful diagnostic tool. This is in contrast with our present study where no rhinomanometry was used. In conclusion, deviated nasal septum is very strongly associated with nasal valve collapse. A comprehensive assessment of nasal valve dysfunction is important for all patients with nasal obstruction, and failure to address both septal deviation and nasal valve collapse concurrently risks suboptimal management of the patients. These are my references. Thank you.
Very good, confident presentation.
Thank you,
I
ma'am.
just have one query. You are saying it is a retrospective study.
Yes, ma'am.
And in the very first slide only you told that it is difficult to evaluate the nasal valves and not routinely done. So how did you do this?
Ma'am, it's a
study?
retrospective study, but since it's our institute, we do a lot of septorhinoplasties also, functional septorhinoplasty. We do evaluate in our institute. And that is why we wanted to go back, and though there are some patients who need septorhinoplasty for this, we have not evaluated the functional outcome here. We have not quantified the nasal obstruction as done in the nose score. But we do the physical examination of all patients. These are the things which are done for all
Okay,
patients.
because if you are evaluating them already, this study would, like, you would come to this result
Ma'am, we are
even
actually
without
trying to say that even though there is a nasal valve dysfunction, patients are not counseled for doing a functional septorhinoplasty because it was a retrospective study. We could not compare the outcomes of a septoplasty with septorhinoplasty. However, we wanted to stress that there is nasal valve dysfunction, which the patient often does not himself want to address, as also the surgeons sometimes who are not very conversant with a functional septorhinoplasty technique. And what happens is we end up giving so a part of the population is left behind because patients are mainly, because it changes the nasal aesthetics sometimes when we address the nasal valve area. So the patient is not counseled enough to undergo that procedure.
Okay, so it is more for patient counseling.
No, it is not for patient counseling, ma'am. It is also for doctors, because we often, whenever there is a septal deviation, we just think about it. We do not, even someone who does not do it, I'm thinking about, we do it, so we see all patients for this.
Okay.
But someone who does not do it would say that, since you do a rhinoplasty, you all counsel all patients for rhinoplasty. So this is what I want to contradict. I mean to say that we generally have nasal valve collapse, and that is why we do a functional rhinoplasty.
Right, right. Therefore, my question was that how it will help the patient.
Yes, ma'am, it will help the patient, because at least if we know that there is a nasal valve collapse happening there, we will counsel him accordingly. The choice remains his, whether he is okay to risk a change in his nasal aesthetics for getting better functional outcome. So that is how it will benefit the patient. So this study has not evaluated the nasal obstruction symptom index that we compare for septoplasty and septorhinoplasty. But we still have to counsel the patient regarding this, and if we do not see it, then we cannot tell the patient about it.
Right. So I think you can take this study further.
Pardon?
You can take this study further.
Yes, ma'am, because this was retrospective, I could not get the data for the nose score, preoperative nose score. So now, because when it will become prospective, I can do the nose score also.
Right.
Thank you very much.
Thank you, Dr. Kamalika. Next speaker is Dr. Swati Sahai from microbiology.
A very good afternoon to one and all. The title of the paper is Citrobacter coceri as an emerging pathogen in orthopedic infection, a case series. As we know, Citrobacter coceri is a motile, facultatively anaerobic member of Enterobacteriaceae or Enterobacterales. It is best known to cause neonatal meningitis and brain abscess, and to some extent urinary tract infections, pneumonia, bacteremia, and hepatobiliary infections. Now, this organism's involvement in orthopedic surgical site infection has been regarded as very rare. Emerging reports suggest that this organism possesses the capacity to colonize the post-operative wounds, invade deep soft tissues, and establish the infection in bone as well as orthopedic implants. And this infection is particularly important in older adults, patients with chronic comorbidities, and individuals with prolonged hospitalization or prior antibiotic exposure. Published data on C. coceri orthopedic infection remains very sparse. As of March 2025, there have been only 15 cases in musculoskeletal infection which have been reported due to Citrobacter coceri. To address this gap, this case series describes 4 cases of post-op wound infection in which C. coceri was isolated from the pus samples. Thus, this study highlights the organism emerging relevance in orthopedic surgical practice and the need for increased clinical awareness with microbiological diagnosis and tailored antimicrobial strategies. Material and methods, as this is a case series of less than 5 cases, permission from the head of the institute was taken to access the data as per the institute policy. All data were anonymized prior to compilation of the case series. Study design and setting, this is a retrospective single-center case series of consecutive adult patients who developed post-operative orthopedic surgical site infections with isolation of C. coceri from deep wound or pus specimens. Medical records, operative notes, and microbiology lab data were reviewed. The study was based on routine diagnostic samples submitted to the lab. For data collection for each of the 4 cases, the clinical as well as lab data details were recorded. So here we present 4 cases. The case 1 was a 60-year-old male with 17-month-old wound over the right leg, which gradually worsened over 4 days. He complained of foul-smelling discharge from the wound. He was a known case of non-healing ulcer of 1.5 years duration with history of trauma, and the wound was not responding to routine care. There was no comorbidities. He was diagnosed as osteomyelitis of the right calcaneum and underwent IND of the right leg wounds along with debridement, followed by split skin graft applied over the right leg. Pus discharge was noted on the 3rd post-operative day. In the second case, there is this 45-year-old male who sustained injuries following a fall. There was no presence of any comorbidity. He was diagnosed as right intertrochanteric fracture of the femur, operated by ORIF, open reduction internal fixation, with proximal femoral nail encirclage. Pus discharge was noted on 15th post-op day. Case 3 is a 71-year-old male who sustained injury following an RTA with history of pulmonary tuberculosis who was on treatment. His diagnosis was right intertrochanteric fracture of the femur, distal and radius fracture, and metatarsal fracture of the left side. He underwent ORIF and nailing. He presented to the OPD 7 months later with a history of pus discharge from the operative site. The 4th case is a 96-year-old male who sustained injuries from a fall at home. He had a history of hypertension of more than 30 years. He was on treatment. His diagnosis was post-traumatic fracture of the left neck of femur and underwent bipolar hemiarthroplasty. Pus discharge was noted on the 3rd post-op day. This study was based on routine diagnostic samples which were submitted to the lab. As per the protocol followed in the lab, a direct microscopy including gram stain and culture by inoculation on blood agar and McConkey agar was done. Phenotypic identification of Citrobacter coceri was done as per the conventional biochemical reactions, and the identification was done according to the reference biochemical profiles of Citrobacter coceri. Manual ABST was done by Kirby-Bauer diffusion method and interpreted according to CLSI guidelines of 2025. The panel of antibiotics used were beta-lactams, carbapinins, aminoglycosides, fluoroquinolones, folate pathway inhibitor, and tetracycline. The isolate is considered MDR, multi-drug resistant, if it is resistant to more than 1 drug in more than equal to 3 of the above antimicrobial categories. Along with the ABST, the various mechanisms of resistance were studied, which included ESBL, AMC beta-lactamase, and carbapinimase, for which indicator drug was included in the panel. Results, a total of 4 orthopedic post-op wound infection have been included. in which all 4 cases we could isolate Citrobacter coceri as the causative agent. The antimicrobial susceptibility pattern showed marked variability. The first case was susceptible only to ciprofloxacin, gentamicin, tetrafloxacin and oflox, tetracycline and oflox. Second case to amikacin, meropenem and cotrimoxazole. Third to tetracycline and fourth to aztreonam. Discussion. Now, as we know, Citrobacter coceri has been less frequently isolated from other Citrobacter species. Especially Citrobacter fluendi is commonly observed in all cases of post-op infection or UTI. However, Citrobacter coceri is emerging as a clinically significant pathogen in orthopedic infection, and its presence in all post-op wound in this series highlights not only the increasing role of gram-negative organisms, but also of Citrobacter coceri. These cases usually have been traditionally dominated by gram-positive bacteria such as Staphylococcus aureus. The isolates demonstrated wide beta-lactam resistance, including to ampicillins, early cephalosporins, piperacillin agents. All of these cases showed wide resistance, suggesting ESBL AMC mechanisms, and even meropenem-resistant organisms were also there. So emerging carbapenem resistance emphasizes the need for targeting testing rather than assuming lower resistance based on its rarity. Infections occurred in high-risk post-op settings, as mentioned, and therefore these cases demonstrate the value of phenotypic identification and manual ABST where automated systems are not available. Despite its rarity, C. coceri warrants close clinical vigilance because of its potential for resistance development and its capacity to complicate post-operative orthopedic wounds. The limitation of the study was the species could not be confirmed by Vitek or MALDI-TOF as automated identification systems are not available in our lab. Conclusion, Citrobacter coceri is an emerging pathogen in orthopedic surgical site infection which is capable of causing post-operative wound infection. These have high antimicrobial susceptibility and needs accurate microbiological diagnosis and targeted therapy. Continued surveillance and awareness of gram-negative pathogens in orthopedic settings are necessary to improve patient outcomes, particularly in elderly and high-risk populations. These are my references. Okay,
it was a nice case series. So 4 cases have been studied.
Yes,
and you are warranting that this is a new pathogen which is emerging in orthopedic infections.
Yes, ma'am.
So how would you like to take your study further, or what is your conclusion?
Ma'am, to further validate the Citrobacter coceri as a major pathogen, a cross-section study should be done, a proper original research paper, I would say, maybe over a span of few years, as the number of pathogens what we isolate as coceri is very less. So worldwide, only 15 cases have been caused due to Citrobacter coceri, which is documented in medical literature.
So worldwide 15, and
Yes,
among those 15, 4 are in
No,
Myanmar.
ma'am. As of March 25, 15 cases of musculoskeletal infection has been documented by Citrobacter coceri. Usually in orthopedic infections, we suspect Staph aureus, and therefore the empirical treatment used by orthopedicians is usually vancomycin or linezolid. But now if we are bringing these 4 cases of coceri, we have to not only just consider that major cause can be a GNB also, but among GNB, rare pathogens is also possible. So
And you are
instead
not
of
still able to confirm the coceri in your last slide you mentioned.
Yes, ma'am.
Because you-
Actually, our
yeah.
lab does conventional method that takes a minimum of 48 hours.
Okay.
So if we have Vitek or MALDI-TOF, our confirmation will be
Because
exact.
if it is the same organism, sensitivity should be at least correlating, like the sensitivity what you showed for the 4
No,
cases.
ma'am. It's a hospital-acquired infection, and depending on the data, we don't have last 5 years or 10 years data to correlate what is the sensitivity for this pathogen specifically. So this is just an observation which we found in a lab, that we got 4 cases which had a varied susceptibility, but all these were multi-drug resistant organisms.
So rather than case series, you would like to extend it further?
Yeah, as a cross-sectional study and prospective observational study.
Thank you.
Thank you, ma'am.
Thank you, doctor. Our next presenter is Dr. Manas Pusalkar from Ortho.
respected judges, respected chairpersons, and respected audience. So I'm going to talk hospital. So what is a giant cell tumor? It's a locally aggressive benign tumor of the bone which is rich in osteoclast. It was first described by Sir Ashley Cooper in 1818. This is the commonest benign tumor of the bone which has a propensity for the local recurrence even after the surgical excision. According to the Mayo Clinic series, giant cell tumor represents 5% of the neoplasms of the bone. So the etiology is poorly understood. It happens in the third decade of the life after the skeletal maturity. So it's very, very rare before the skeletal maturity. Only 2% of the patients are of the pediatric age group before the physis is closed. If it happens in the pediatric age, these tumors are more aggressive. Spinal involvement, sacral involvement is very rare. The most commonest site is the epiphyseal-metaphyseal region of the bone. Distal femur remains the most common site, distal, the proximal tibia, the distal radius, the distal fibula. So most of the tumors, they are symptomatic. They don't present with an asymptomatic condition. Pain is the commonest symptom which the patient will have. It can vary in intensity from mild, dragging pain, severe pain, and duration of the pain will be from couple of weeks to couple of months. Trauma can be an incidental finding, and 5 to 10% of the patients will have a pathological fracture. And this is the new thing which has emerged, that the neoplastic cells express rankle active osteoclast like giant cells, and H3F3A gene mutation has been linked to this etiology. So histopathologically, the tumor is eccentric, and grossly it's reddish brown to yellow in color with areas of hemorrhage and areas of cysts. But the hallmark is the microscopic examination, which contains multinucleated giant cells in a mononuclear stroma. Giant cells can be present in other conditions, but the number of the giant cells which are present is most important thing. Clinical presentation is pain, swelling, limitation of the movement, or rarely pathological fracture. This is how the giant cell tumor of the proximal tibia will look on an X-ray. You can see the expansile bony lytic lesion with multiple septations in the proximal. So this is typically, the type of the bone destruction is typically called as a soap bubble appearance. Further imaging studies are needed, like CT scan and MRI scan. So the grading of giant cell tumor is very simple. The grade 1 is intact cortex, the grade 2 is thinned and expanded cortex, and the grade 3 is cortical destruction and soft tissue extension. So the biggest differential diagnosis is aneurysmal bone cyst, but this usually happens before the closure of the physis. That means it happens usually in the age between 10 to 15 years, whereas giant cell tumor happens after the skeletal maturity. So histopathology will confirm the diagnosis, which will have multinucleated giant cells and atypical giant cells. So the treatment is, the aim of the treatment is the local control, the preservation of the joint function, and the mainstay of the treatment is surgery, surgical intervention. So these are the surgical options. The historical treatment was intraregional curettage and appropriate reconstruction. Then the treatment evolved with the curettage with the use of adjuvants, which is sclerosing agents like phenol, liquid nitrogen, the use of cement and polydaconol. And then extended curettage, that is aggressive curettage, and for unresectable tumors, en bloc resection. So what is the role of adjuvants? Polymethyl methacrylate, this is the bone cement. It causes the thermal necrosis, and it fills the defect by giving a good structure. Then hydrogen peroxide, phenol, cryotherapy, argon beam coagulation, these are the adjuvants. Most of them are sclerosing agents. Then denosumab is a new line of treatment which is used for unresectable tumors and inoperable areas like sacrum. So this tumor is known for recurrence. If you do a simple excisional, if you do a simple curettage, the rate of recurrence can be 30 to 50%, which is very, very big. Extended curettage will decrease the rate to 10 to 15%, and most of the recurrences happens in first 2 years of the life. Pulmonary metastasis is very rare, and malignant transformation is rare. So follow-up of the patients is very necessary by taking the local x-rays, and if you are worried of the chest, then we do the chest x-rays. So this is the case of a 20-year-old gentleman who presented with our clinic for a second opinion. His lesion in the left calcaneum was missed by an orthopedic surgeon from a remote area. But if you see it clearly and examine the X-ray on the right side, you can clearly see that there is a destruction of the calcaneum near the posterior tuberosity. So he presented with us for a second opinion after 9 months, and you can see on the image on the right-hand side that the entire calcaneum is completely destructed. So if I go back to the previous X-ray, you can see how much the calcaneum has destructed in the period of 12 months. This is a preoperative CT scan which shows the nearly 80 to 90% of the destruction of the calcaneum and a thin shelf of the bone which is remaining at the calcaneocuboid joint and at the talocalcaneum joint. This is the preoperative MRI which shows an intense lesion here. So the surgery was planned. What we did was an extensile lateral approach, exposed the whole calcaneum, and the calcaneum was exposed by taking down 3 K wires, one in the cuboid, one in the metatarsal. So the entire lateral wall of the calcaneum was taken down. This is the image on the right-hand side, which shows the entire lateral wall of the calcaneum which was taken down. Extended curettage was done, and we used polydecanol as an adjuvant to sclerose the walls of the tumor. Then we used the local diathermy to burn the walls of the tumor, and then the whole of the defect was packed with the cement, and then the lateral wall of the calcaneum was repositioned. So these are the post-operative X-rays after 21 months. The patient is doing functionally well. There is no pain at all. This is the function of the patient. He is able to do full plantar flexion, full dorsiflexion, and able to carry out day-to-day activities of the life. So in the end, what I will say is that this was a bad chapter of his life. It didn't dictate his entire life. And I'll only add one point, that cancer didn't shatter his hope. It didn't shatter his spirit. He's making his livelihood as a tea vendor and able to walk 2 to 3 kilometers per day without any pain. Thank you.
Different case. I think you should have focused more on your case. So it was after 21 months. So
Yes.
currently almost 2 years have been done. For
Yes,
this.
yes, he's 2 years down the line now.
Okay. So that was the treatment different from what you do routinely for giant cell tumor?
Sorry, I didn't get the question.
Why this case is different? What was different in this? Presentation or
The different point was only one, the anatomical location.
Yeah.
Because most of these tumors are present around the
Wrong.
knee. The knee is a better area to operate compared to the calcaneum. Calcaneum is not a good area to operate because of the wound breakdown and the wound infection.
Okay. So my question, are you including the case reports in the paper presentation? Is it allowed? Case reports? Poster, huh? Okay.
The only reason I presented this case is that we have done couple of cases like this in our hospital, but those cases are missing the follow-up.
Okay. So you can have case series
So
next
if
time.
we had the follow-ups of those patients, we could have presented a case series.
Case series, yes.
But those patients didn't turn for follow-up at any chance.
Okay. Okay. Thank you.
Thanks.
Thank you, sir. Judges, we have our next participant, Dr. Nivedita. Our next speaker is Dr. Nivedita from ENT.
Yeah. Hello, good afternoon everyone. Myself Dr. Nivedita Narayankar. I am an ENT senior resident in Department of ENT in Mymar Medical College. So today I am going to discuss about a prospective study to assess the effect of topical levobupivacaine in post-tonsillectomy pain management. So tonsillectomy is one of the most commonly performed procedures in otolaryngology. Pain is a significant aspect of post-operative patient morbidity in tonsillectomy. The use of local anesthetic by infiltration or topical application have been advocated as a way of reducing post-operative pain. Aims and objectives of the study are to assess the effect of topical levobupivacaine hydrochloride on severity of pain after tonsillectomy with a control study. And also to evaluate the functional oral intake following the post-tonsillectomy period. Material and methods of the study are: the sample collection was done from both OPD and IPD of the Department of ENT, MBJ Medical College, Hoskote, Bangalore. It was a randomized prospective control study. The study period was for about 2 years, that is October 2019 to September 2021. The inclusion and exclusion criteria include: the inclusion criteria where all the patients age group of 5 to 25 years of age and who are with the diagnosis of chronic tonsillitis, patient willing to give an informed consent for the tonsillectomy. Exclusion criteria was patient undergoing tonsillectomy for conditions other than chronic tonsillitis, that is such as peritonsillar abscess, tonsillolith, foreign body tonsil, etc. And other exclusion criteria include hypersensitivity to levobupivacaine and patients with psychiatric illness. Sample size of 76 cases of chronic tonsillitis of age of 5 to 25 years of patients underwent tonsillectomy in our institute for about 2 years of duration. So a detailed history and clinical examination of a patient was done. Pre-anesthetic evaluation was done, following which levobupivacaine test dose was given to the patients. Patient underwent tonsillectomy by using standard dissection and snare method under general anesthesia, and hemostasis was achieved. Patients were divided into group A and group B. That is, group A is a study group which includes the levobupivacaine application topically of around 5 ml of levobupivacaine was applied in each tonsillar fossa after achieving a hemostasis. And in group B, the normal saline was used as a placebo. So after the surgery, severity of pain was assessed at 2, 4, 6, 12, and 24 hours of post-operative period using Wong-Baker Facius Pain Scale. So these are few pictures of tonsillectomy. This was our scale used for assessing the pain by the patients. This is a score used functional oral intake scale by which we assess the oral intake of the patient, where level 1 shows the nothing by mouth and level 7 shows the total oral diet with no restriction. The results of the study were mean age group in the study group was 19.13 with a standard deviation of 4.79 plus or minus years, of majority of which were females, that is 63%. The outcome parameters were compared using t-test, which showed a p-value less than 0.05 at 2, 4, 6, 12, and 24 hours. The results, this is a tabular form which shows the comparison of pain score with a study and a control group. So you can see here at all, that is 2, 4, 6, 12, and 24 hours, it shows a gradual decrease in the pain by the patients, whereas it is higher side on the control group. So you can see average of 5.01, which is seen in the study group, and 5.53 is seen in the control group. So this is a graphical representation showing the same one. So red one shows the severity of pain in the group B, and blue one shows the pain assessment in the study group. So study group shows a lesser pain. And the other side you can see a line graph which represents the early oral intake of the patients under the study group. Okay, so it is lesser pain, so more is the oral intake. So that was the basic thing of our study. So discussion about the study. So many protocols have been tried to minimize the factors in result of post-tonsillectomy pain management. The surgical technique is also important. Leach et al. Have compared a sharp dissection and snare technique with the electrocautery. The electrocautery may cause more pain and the sharp dissection than the sharp dissection alone. So we used a dissection and snare technique which exclusively in our study to avoid the pain related to the surgically. So we know the analgesic effects of anti-inflammatory drugs are effective in post-tonsillectomy patients, but these agents are also strong inhibitors of prostaglandins and platelets and may cause a significant post-operative bleeding. These studies are trying to control the post-tonsillectomy pain without using anti-inflammatory drugs. Many studies have been done to relieve the post-tonsillectomy pain by infiltration of local anesthetic into the peritonsillar fossa, but we preferred a topical application of levobupivacaine, that is a new local anesthetic. It is an S-enantiomer of bupivacaine and has an advantage over a less motile blockage and more prolonged post-operative effect with comparison with the bupivacaine. So Dameron et al. Compared the use of pre-incisional lidocaine 2% with the epinephrine and levobupivacaine for post-operative analgesia and during the nasoseptal surgery, and they reported a local infiltration of levobupivacaine which was significantly more potent. Karan S. et al. Reported a peritonsillar infiltration of levobupivacaine alone or with addition of magnesium to provide a significant effect of relieving a pain post-operatively. A double-blind prospective randomized control study, Element S. et al., with a topical levobupivacaine reduced the morbidity in post-tonsillectomy patients, but only for 24 hours. Most previous studies have used a visual analog dynamic pain assessment, and other studies have used a functional oral intake scale for this study. But in our knowledge, in this study, we have preferred a topical levobupivacaine since infiltration technique carries a risk of accidental intravascular injection, which may cause a convulsions and cardiac arrest. And these are other things. In our knowledge, so there are no published literature of a prospective study to assess the topical levobupivacaine in post-tonsillectomy pain, which assess both the post-tonsillectomy pain assessment and the early oral intake by the patients. So we conclude with a tonsillectomy is one of the most common surgical procedure carried by otolaryngologists. Dissection and snare method is one of the oldest and mostly practiced in world over. So we conclude that topical levobupivacaine seems to be safe, easy medication, in control of post-operative throat pain for tonsillectomy patients. And it also shows early oral intake by the patients, and it is proved statistically. So these are my references. Thank you. Any questions?
So I can see the references, like since long back it is being used.
Yes.
So are you not using it then routinely? Still, the study need to be conducted?
Study has been conducted, ma'am, already. We have proved it. It is significant.
No. I'm asking, yeah, others see, we can see the studies from 92, 97, 89. So my question is then what was the novelty?
What was the?
Novelty. If it has been used so far, what was the novelty in this research?
There is no restriction as such, ma'am. We can use. It depends on the surgeon and surgeon's preference, basically. There is no harm in continuing using this particular drug as such.
Okay.
And we have used topically, so there is no like disadvantage or any adverse effect per se.
So using it topically was your novelty. Have you used topically for the first time or less studies regarding this?
We have used topically only, ma'am. That was our first preference because we did not wanted any further complications per se.
Okay. Again, it is a nice study.
Yeah. Thank you, ma'am.
Okay. But madam's question was that you have used local anesthetic agent locally. Injection was given.
Yes.
So wasn't it tried before?
Was it?
It tried before. Has the similar study been conducted before?
Similar study was conducted before, but only levobupivacaine was used topically, ma'am.
Acha.
Yes.
So it was not given injection in that region?
Yes.
Okay.
There was no avoiding its bupivacaine was used instead of levobupivacaine by the other studies.
Okay.
Like plain bupivacaine was used. So similarly, we have taken levobupivacaine. There are other studies which use ropivacaine, bupivacaine topical application.
So which is best amongst all?
Levobupivacaine is comparatively best, ma'am, because in other studies, like what is the difference between other studies and our studies? They have compared with each anesthetic. Like ropivacaine was compared with the bupivacaine, and levobupivacaine plain was compared with the levobupivacaine and magnesium sulfate. That was the thing. But in our study, we have compared only levobupivacaine with the placebo.
Are there any side effects of using this technique?
No, ma'am. There were no side effects noted during the study.
Okay. Okay. Yes. Thank you.
Thank you.
Thank you, ma'am. Last presenter for today is Dr. Anish Bhatt from Department of Psychiatry.
So good afternoon all. So today I'm going to present a study of effect of entrance exam on psychological health of medical graduate. So we know our medical graduate pass through a lot of stress prior to a job. Competition doesn't stop. So what effects it causes on a mental health of a medical undergraduate? We studied over here and we got a lot of findings out of it. So let us go through the study. So entry into medical postgraduate is highly competitive in India. Graduates attempting the exams are not only interns, but also pupils who are aiming to score better than the previous achieved score. So it is not the fresh batch, but also previous batches. Aspirants preparing for this entrance exam may experience problem with their physical and mental health that could have a long-term impact on them. A cross-sectional study performed by Dr. Ashish Srivastava et al. On assessment of depression, anxiety, and stress among students, these are not medical students, students preparing for various competitive exams showed prevalence of moderate depression with 20.3%, 14.8%, whereas with moderate stress level. 27.3% of the total participants were having a severe anxiety. So currently, there is a paucity of research on the prevalence of psychological disorder among the medical graduate taking the PG entrance examination. So that's why we conducted this study. So what was the methodology of study? We used a socio-demographic profile, academic profile questionnaire, which was a semi-structured questionnaire to address the different objective of the study. It included age, gender, email address, age of graduation, duration of preparation of entrance exam, number of attempts, increment in ranking after the taking multiple attempts, need for PG entrance exam guidance, psychological counseling or help taken or needed during the period. We used DAS 21 questionnaire, which is depression, anxiety and stress scale 21. It has a 21 questions. It is a self-reporting scale and it is a validated reliable scale screening tool used to screen the prevalence of depression, anxiety and stress symptoms. So it has 21 questions, 7 items divided into 3 subscales, that is stress, anxiety and depression. One on the scale of 0 to 3, they have to mark their feelings depending upon the last week's assessment of self. Depending on the cutoff values, depression, anxiety and stress was categorized into mild, moderate, severe and extremely severe level. So study was a cross-sectional study conducted in our own college, Myanmar Medical College, and also we circulated the Google Forms to different aspirants, PG aspirants. Sample size we achieved was 456 medical graduate appearing for PG entrance exams in India. Data collection was collected through Google Forms and circulated via contacts and institutional help all over the India. Graduates willing to participate were asked to fill form with due consent. Statistical analysis was done by chi-square test. P-values 0.05 were considered, less than 0.05 were considered significant, with 95% confidence interval. So what results we got? So the survey included overall sample size was given 456, but we got more students, that is 520 students. So 520 medical graduates appearing for PG entrance exam all over the India we got. There were 336 female students and 184 male students. Median age was around 24 years. Depressive symptoms and 76% of candidates had anxiety. 1/3 were found themselves to have a stress. Depression severity from mild, moderate to severe increased with increase in duration of preparation. So longer the duration of preparation, they had more severity of stress and anxiety. Severity of anxiety and depression with percentage of participants having moderate, severe and extremely severe anxiety increases with respect of attempts. So duration of preparation and number of attempts both increase the anxiety and severity. The need for psychological help mentioned by 65.38% of participants. So it is significant in the sense that they felt the need that they want a psychological counseling, they want a counseling for stress and anxiety level. Almost half of the participants, that is 46%, 47% around, were not in favor of a gap year, but 19% were ready to take gap year if they did not get their desired rank or college. So again, most of the people were not ready for taking a gap year. So these are the tabulated results. So same thing what I have mentioned, duration of preparation increases the anxiety, duration of number of attempts again increases the anxiety and the stress in the individual. This is in relation to amount of time spent in preparation, the severity of anxiety and percentage of those experiencing mild, moderate and severe or extremely severe increases with the duration. Then coming to discussions, the present study finding revealed a higher prevalence of depression, anxiety and stress among candidates compared to the earlier study. The similar findings were noted with the stress 29% and anxiety 39% were reported in the study conducted among medical interns of Malaysia who were preparing for the medical postgraduate entrance examination. A slight increase in depression is seen when compared between the age group of 22 to 24-year-old and more than 28-year-old. So more the age, they felt more stress and more depression. So it is 53.85% people of 28-year-old graduates felt the stress. Nevertheless, anxiety remained constant throughout the age groups, that is 22 to 24 years old, whereas other also they were around 45 to 41%. In a study conducted among primary care physicians in China, significant difference in anxiety depression were reported in different age groups. So there was a study from China which reported different percentage of anxiety in different age group of primary care physicians who were preparing for exams. Limitation of the study. The data obtained in our study were more subjective because the scale itself is a subjective scale. It is a self-reported questionnaire. Percentage of women enrolled in this study were more than the males, so which could be due to randomization of the study, or maybe it's the data collection or sample collection. Also, whether the non-academic stressors were exacerbating pre-existing psychological symptoms caused by entrance examination should have been included in the study. So, other than exam stressor, there may be relationship issues or maybe financial issues, lot of other issues can be there that should have been included in the study. Employment status of the candidate while preparing exam. So some candidates are employed, so they are facing dual stress. So that also we didn't include in the study, which causes a limitation for this study. The study has opened up the need for, main target of the study was to open up the psychological need. So it has opened up the psychological need to help or counseling for the students who are preparing for competitive exam in medical stream, which is currently ignored. Lot of students do not seek help, even they are suffering from stress or depressive symptoms. Study finding indicates high level of anxiety and depression among the PG aspirants. So these are my references. Thank you very much.
Very nice.
Thank you, ma'am.
But one of the criteria for any research proposal is it should be researchable or answerable. I don't know whether we are going to have answer for this. More percentage of females than males, 63 versus 35. Do you have any reason for that,
Yes,
or
ma'am.
it was
Because
just
now,
a survey?
yes, ma'am. Nowadays, in medical profession, in the recent batches, if you see last 5-6 years batches, admissions of female undergraduates are more than male undergraduates. So definitely the people who are preparing for the entrance are females are more than males.
No, but you have done this study in students who have already given the exam or who are about to give,
Correct.
maybe interns.
Correct.
So what you are saying, I agree to that, but this rise I am seeing in last 3 to 4 years. So your study was done on the batches in which males were more.
Maybe it is a data collection by us,
Yeah,
because
probably.
we have circulated it through Google
Yeah.
form, and maybe females are more
Willingness
proactive
of-
to
yeah.
give
And
the
they
answers.
also have the stress of obstetric career.
Yes. And another answer question which you asked, that we need whether this study addresses the need or solution. So we are finding a problem over here, how much a problem statement is. So depending on the problem statement, if 68% of people need psychological help, definitely we can start a psychological counseling centers for these people, or maybe the psychiatry departments in the medical college itself can have such units.
Sir, one thing can be done when internship distribution is done. At that time, the intervention can be done and such help can be offered to the interns.
Correct.
So that interns will be aware that such kind of help is available and
Correct.
they can have accessibility to it.
Correct, ma'am.
That is the right time.
That's what the plan is, because that is where they start with the competitive
Right.
things. Yes,
But
ma'am.
that time they become serious.
Yeah.
They are preparing from first year
Yeah,
nowadays.
I know. Marrow starts from first year.
First year. From first year they will start bitching the student.
Yes,
that-
ma'am.
Sir, limitations you have already pointed. My question was the same, that how the other stressors can be eliminated, which is already, other stressors can
Yes.
be there.
Yes.
So which are not eliminated in the
Correct.
current study.
Correct.
And most of the students are for the first attempt.
Yeah.
Maximum sample size.
Correct.
Second attempt, third attempt.
Very less.
Less.
Less. Yeah.
Thank you, sir.
Thank you very much, ma'am. Thank you.
Thank you, sir. So with this, we come to the end of the afternoon session. I thank the judges once again for being patient with us till the afternoon. Now I'd request Sandhya Kulkarni ma'am, Vice Principal and Professor of Microbiology, to felicitate Dr. Smita Pawar ma'am. Yes, yes, please, on the dais. The results will be disclosed tomorrow afternoon. Applause. Let's have a round of applause for them. Thank you, ma'am. So we come to an end at the afternoon session. We'll see you all tomorrow.